أي.
بسم الله الرحمن الرحيم. الحمد لله أقصى مبلغ الحمد، والشكر لله من قبل ومن بعد. الحمد لله عن سمع وعن بصر، الحمد لله عن عقل وعن جسد، الحمد لله خلق اللوح والقلم، والصلاة والسلام على سيدنا محمد عليه الصلاة والسلام، طب القلوب ودوائها، وعافية الأبدان وشفائها، ونور الأبصار وضيائها. الأخوة الجمعية اليمنية لأطباء العيون، الأخوة الرعاة شركة الجزيرة والخليج، الاستشاري وأخصائي طب وجراحة العيون، أخصائي البصريات والعدسات التصحيحية، الأخوة الزملاء والأطباء المقيمين، الضيوف الكرام، كلا باسمه وصفته، أحييكم بتحية الإسلام الخالدة الثابتة اللازمة، بتحية أهل الجنة، وتحيتهم فيها سلام. فالسلام عليكم ورحمته تعالى وبركاته، وجمعتكم مباركة، وأهلا وسهلا ومرحبا بكم في اليوم العالمي لعدسات راينر. آيات صدق لا يمل سماعها، أعجزت فيها بلاغة النقاد، نص حكيم فصلت آياته تشفى به الأرواح والأجساد. إن خير ما نستهل به لقاءنا لهذا اليوم آيات من الذكر الحكيم يتلوها على مسامعنا الأخ مازن البركاني، فليتفضل.
أعوذ بالله من الشيطان الرجيم. يا أيها الذين آمنوا اتقوا الله حق تقاته ولا تموتن إلا وأنتم مسلمون واعتصموا بحبل الله جميعا ولا تفرقوا واذكروا نعمة الله عليكم إذ كنتم أعداء فألف بين قلوبكم فأصبحتم بنعمته إخوانا وكنتم على شفا حفرة من النار فأنقذكم منها كذلك يبين الله لكم آياته لعلكم تهتدون. ولتكن منكم أمة يدعون إلى الخير ويأمرون بالمعروف وينهون عن المنكر وأولئك هم المفلحون. ولا تكونوا كالذين تفرقوا واختلفوا من بعد ما جاءهم البينات فأولئك لهم عذاب عظيم. صدق الله العظيم.
صدق الله العظيم. وطني في واوه الوفاء وفي طائه الطيبة والهناء، أما نونه ففيها النبل والنماء. إنه الحضن الدافئ الذي سيبقى لنا مأوى مهما كبرنا وتبدلت بنا الأحوال. والآن فليتفضل الحضور الكريم للوقوف للسلام الوطني. لن ترى الدنيا على أرضي وصيا. شكرا لكم جميعا. السادة الكرام، نبقى الآن وإياكم مع كلمة الجمعية اليمنية لأطباء العيون يلقيها الدكتور محمد عبد الله إبراهيم، فليتفضل.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم وجمعة مباركة. يسر الهيئة الإدارية يسر الهيئة الإدارية لأطباء العيون أن ترحب بكم في هذا اللقاء في فعالية جديدة كما عودناكم ووعدناكم، كي نستفيد من كل فعالية تقام لنرتقي ونجدد معلوماتنا الطبية في مجال العيون وما يتعلق بهذه من منتجات قيمة. وهذه الفعالية التي تقام هذا اليوم تسلط الضوء على إحدى هذه المنتجات، لذا نتمنى أن ننال بعض المعلومات عن عدسات راينر حتى تعم الفائدة. وفي الأخير أشكر الجهة الداعمة لهذه الفعالية وهي شركة الجزيرة والخليج كما عودتنا دائما، كما أشكر جميع الحضور. وأحب أن أنوه في هذه أن لدينا فعالية قادمة إن شاء الله عن الICL، والتي سيكون موعدها يوم الجمعة 22 سبتمبر بإذن الله. والسلام عليكم ورحمة الله وبركاته.
ونبقى الآن مع كلمة شركة الجزيرة والخليج يلقيها علينا الدكتور إياد يوسف بطيبط، فليتفضل.
السلام عليكم ورحمة الله وبركاته. رئيس جامعة المستقبل الأستاذ دكتور محفوظ الدكتور عبد الهادي الهمداني، أستاذ دكتور محفوظ ما مشموس رئيس جمعية أطباء العيون، الطبيبات، الحضور جميعا. أتقدم بالشكر الجزيل لجمعية أطباء العيون إتاحتها الفرصة لنا برعاية اليوم العلمي الخاص بعدسات راينر. أتمنى للجميع الاستفادة الكاملة، وأحب أن أقدم رؤساء الجلسة الأولى الدكتور محمد العنسي والدكتور حجر، وأهلا وسهلا بكم. دكتور إسماعيل حجر.
الحضور الكريم، نبقى الآن وإياكم مع برنامج وفعاليات اليوم العلمي لعدسات راينر، ونتمنى لكم وافر الإفادة وتمام التوفيق.
بسم الله الرحمن الرحيم. اختصارا للوقت، أرجو من المحاضرين جميعا اختصار الوقت قدر الإمكان. احنا متأخرين تقريبا 20 دقيقة، 3 محاضرات تقريبا. أول جلسة نبدأها أو محاضرة مع دكتور علي الأشول، عنوانها راي 1 ترايفوكال تيبس اند تريكس. تفضل دكتور علي.
السلام عليكم ورحمة الله. صباح الخير وجمعة مباركة. نبدأ البرزنتيشن titled Ray 1 Trifocal IOL Tips and Tricks. طبعا البيشنت الآن expectation post cataract surgery تغير مع الوقت. أصبح الآن الكاتاراكت surgery becoming more and more refractive surgery at the same time. المريض يشتي نظر كويس يعني good vision for near, far and to be spectacle dependence. The first generation of multifocal intraocular lens were designed to provide patient good distance and near vision, but intermediate was not satisfactory. With increasing طبعا هذه الأيام الuse of computer, tablet, smartphone in recent years أصبح الانترميديت very important، وبالتالي عدسات البريميوم IOL حلت هذه المشكلة. Ray 1 trifocal IOLs has gone long way in addressing this need and designed to achieve good quality of vision for near and intermediate and far as well. Ray 1 trifocal diffractive IOLs combines two diffractive structures عندها over plus 3.5 addition for near and 1.75 diopter addition for intermediate. Consider one of the newest member of Ray 1 family, and that the 16 diffractive rings or steps ال4.5 الأولى diffractive zone and more than 4.5 mm for monofocal and distance vision. طبعا تكون aspheric optic for visual quality, square edge for minimal PCO وهذه very important in this IOL. Fully preloaded IOL across the entire power of range and fully enclosed cartridge with no lens handling وهذا بيساعدنا انه يعمل reduce the risk of lens damage and minimize chance of contamination. Excellent also steps system injector. نحط بس ال OVD في الاوبننج الموجوده. Easy handling design with minimal force required and efficient IOL delivery time وبتقلل لنا وقت العمليه. طبعا هي عباره عن sub 2.2 incision. الان المريض هل من حقه انه يجي للسؤال هذا what sort of intraocular lens will I have inside my eye؟ في عندنا اكثر من عدسات والمريض ممكن الان بدا يختار العدسه اللي يشتيها داخل عينه وكيف تكون وضعها ووضع الفيجوال اكوتي بوست اوب. Many options we have. If we want to implant trifocal IOL with success rate, we have to make good patient selection. وهذه very important in trifocal لأنه البيشنت post op he want to be spectacles independence و good vision for near, far and intermediate. So we prefer to operate on those patients who trust their surgeon skills and capability. And the single most important indication is strong desire to be spectacle independence. We look at them for preoperative refractive errors. Hyperopic patients are the best candidate for such surgery, and I prefer this patient لأنه ما بيشوفش البعيد ولا القريب فبيتحسن بعد العملية بشكل ممتاز. Avoid very short and very long eye or on those patients where they may had LASIK many years ago. طبعا البيشنت الفيري demanding are better off with monofocal lens لانه هيشغلك طول العمر، لا بيشوف لا بعيد ولا قريب حتى لو كان عنده النظر كويس يعني. Patient who are looking for guarantees perfect vision or 100% spectacle independence are not good candidate for trifocal. Proper preoperative evaluation أيضا very important to be success. Detailed preoperative ophthalmic examination. Dry eye disease should be ruled out, corneal pathologies, and rule out some pre-existing ocular disorder, especially with capsular instability. We want to be centralized the IOL, not the center, to have good post-op vision. And previous trauma we have to rule out. Very important issues regarding trifocal وهو accurate biometry. لأن IOL calculation is one of the common cause of patient dissatisfaction. إذا IOL calculation فيه نوع من الغلط يعني ممكن تكون المريض يعني يصبح مشكلة كبيرة، لا هو شايف القريب ولا هو شايف البعيد. في الادفانس بايومتري ماشين سترونجلي ريكومندد. ايضا دائما انا احب انه نعمل كروس تشيكينج باي تو تكنيشن، وكلينيكال correlation with present or past refractive error and fellow eye, especially if you did already the fellow eye ممكن تشوف كيف البوست اوب ريفراكشن، فعلى ضوءها ممكن نقرر للعين الثانيه تكون is better prognosis. نيجي للسيرجيكال تكنيكس. طبعا الفاكو هي نورمال فاكو، في بعض الايشوز او الكونسيرن اللي نهتم فيها، واولها هو ويل سنتر راوندد capsular rhexis and good size usually around 6 mm and thorough removal of viscoelastic from behind the lens and proper positioning of the lens in capsular bag. Good cleaning of posterior capsule with capsular polishing. This is the video for فيكو والترايفوكال. اعتذر بس عن الرداءات يعني مش بدقه عاليه، لكن انه عندنا العطلانه كانت الكاميرا. ممكن نشغل الفيديو. طبعا نورمال فاكو زي ما تكلمنا. نبدا بالكورنيال ووند والتريبان بلو الفيسكو الاستيك. We go for capsular rhexis. As I mentioned before, capsular rhexis is very important, should be centralized, rounded, good capsular rhexis and complete بهذا الشكل. Hydro dissection the same. مع الهيدرو dissection النيوكليوس already goes up, so I prefer usually to do stop and chop, but in this case we do chopping, phaco chopping. طبعا الشوبينج تكنيك حيتكلم عنها الدكتور محمد بعدين.
علي still 2 minutes.
يعني 2 minutes 2 minutes وخلاص. هنا أيضا very important in this step we have to remove completely any lens matter, and usually I did posterior capsular polishing. As we can see here we remove the all and to become clean. ايش فائدتها؟ انه ما بيحصلش PCO. We have to prevent posterior capsular opacification as we can. هنا لو تلاحظوا بعمل البوستيريور capsular polishing. This is very important step. ونيجي على الترايفوكال نزرع العدسة أيضا. very important إنه to make sure the IOL is well centralized in the capsular bag. تلاحظوا إن المالتي فوكال شوية اللي مجرب راينر والمالتي فوكال يعني في تكون أكثر شوية harder than the other ray one. وهنا make sure إنه well centralized. وأيضا at the end we have to make sure meticulous viscoelastic removal. هذه ال 4 hours post op نلاحظ ring very clear and well centralized 1 week post op. طبعا patient expect excellent quality of vision after trifocal implantation. However, complication can occur during or after surgery. هذه حالة من الحالات. طبعا ممكن يحصل لك كابسولار تير، بيوبل تروما، زونيولار دامج، كابسولار رابشر and significant vitreous loss. In this case you have to change to monofocal. هذه trifocal published in each one case report unusual case of hide and seek with broken piece of preloaded trifocal intraocular lens. اعتقد انها مش راينر، ربما شركة ثانية. طبعا الهوم messages at the end of our lecture: appropriate selected patient. The right patient is the right person, or trifocal IOL in the right person work perfectly. Adequate preoperative clinical evaluation is crucial also to post-operative success. Well-centered, good round capsulorrhexis and long-term prevention of PCO is very, very important. But with all these, sometimes even the patient selection and most accurate work can result in refractive surprise. And thank you. What's the next? What's the next عندنا ممكن يكون طبعا السولكوفليكس اللي ما قد دخلتش في اليمن. Sulfoflex can be implanted in pseudophakic IOL and pseudophakic patient for can be trifocal or toric. شكرا.
Thank you, Dr. Ali, for your amazing lecture. Next talk will be with Dr. Nabil Barish, trifocal and retina. Dr. Nabil, جاهز؟
السلام عليكم، جمعتكم مباركة. طبعا أنا أحاول في أن أقدم حاجة اسمها رسالة قبل ما نقدم العملية. هو إيش علاقة الشبكية بالعدسة؟ علاقتها إنها علاقة يعني تناقض، إنه العدسة تفلت على الشبكية وتحتاج أن يتدخل فيها الجراح للتخلص من هذا الشيء. طبعا أنوه للجميع إن هذا تحصل مع الناس كلهم، والآن هوريكم كم نسبة. تقريبا نسبة توصل إلى 3%. لهذا لو سمحتم يا أصدقاء، الشيء طبيعي نعتبره، خاصة مع العمل المكثف في الماء الأبيض. فلهذا إذا حدثت عند أي أحد منكم مشكلة ما تعتبرش هذه مشكلة، والآن الحمد لله موجودين أطباء شبكية ممتازين يقدروا يساعدكم في هذا المجال. فحبيت فقط أن أوصل الرسالة هذه، إنه إذا حدث هذا الشيء لو تكرمتم ما فيش قلق، طبيعي تحدث عند كل الجراحين وتحدث عند جراحين الشبكية أيضا. النسبة موجودة زي ما حكينا ما بين 2 إلى 3%. مع الماء الأبيض توصل إلى 1.8. طبعا صادفتني حالة، وهذا طبيعي تحصل عن جميع الزملاء، أنها يعني موجود العدسة في قعر العين، والعدسة ممكن تسبب دامج. هعمل الآن فيديو بسيط. تفضل يا أستاذ. هنا واضح التغيير ممكن نلاقيه في الفندس. تمام. افتح الفيديو بس. ممكن تحصل أكثر من مشكلة بسبب العدسة. إذا كانت موبايل، العدسة هذه ممكن تؤدي إلى تير في الشبكية وممكن تؤدي إلى انفصال. مثل هذه الحالات تساعد فيها الدكتور الشبكية بكل بساطة، ويقوم بالعمل المناسب لزملاء بحيث أنه يتخلصوا من هذه المشكلة. فلهذا أيها الأعزاء، أي حدث يحصل عند الزملاء لو تكرمتم أول ما تنزل العدسة أو ينزل جزء من النيكليوس توقفوا العملية وتحولوها لجراحة شبكية، ونحن نعملها في الوقت المناسب لكم وبالشكل المطلوب بإذن الله. الكوزس main causes is suboptimal posterior capsule during operation. يعني ممكن يعني تلاحظ في وقت العملية إنه مش واضح بالنسبة لكم هل حدث تير في الكبسول أم لا. نفس الشيء عندما تعملوا زراعة العدسة تشعر إنه الوضع غير مستقر. في هذه الحالة رجاء يعني وقفوا العملية وحولوها للأصدقاء بيقوموا بالواجب وزيادة ومن غير أي تردد. طبعا لضيق الوقت مش هتكلم على كل سلايد، لكن حبيت اوصل الرساله هذه، وهي اهم حاجه انه تحدث هذا الشيء، يحدث عند كل الناس، عن طبيب الشبكيه، عن الاطباء الاخرين، والنسبه عالميا توصل ل 3%. رجاء خاص انه ما حدش يحاول انه يروح بعد العدسه ويحاول يطلعها، لانه ممكن تعمل دامج للشبكيه وتحول حاله الى مراحل اخطر ما هو متوقع. طبعا في بعض الحالات يكون في انفلاميشن، انكريز AOB. المطلوب انه الحاله تهدأ، بس تهدأ الحاله تاخذ وقتها من الاستابيليتي، في ذلك الحال يتدخل الدكتور. ممكن ما يتدخلش في نفس الوقت بسبب التغيرات اللي تحصل في العين والانفلاميشن الموجود. في نان سيرجيكال مانجمنت، هذا اذا كان سوبلكسيشن بسيط ما ياثرش على الفيجن حق المريض. في طرق مختلفه لعمل السيرجيكال مانجمنت، يعني بيجي المريض عنده ديكريز VA، ريزيستنس فيد مايكرورديما. هذه التغيرات اللي حاصله ممكن نقابلها مع المرضى عندما يصير عندهم مثل هذه المشاكل. متى ندخل العمليه؟ في يعني اذا كان متوفر في نفس الوقت طبيب جراح شبكيه في المستشفى، فينصح ان ينزل في نفس الوقت ويعمل استكمال للعمليه. زراعه العدسات تختلف من حاله لاخرى حسب وضع الكبسوله الباز الموجود. هذه الحاله موجود كان انتيرور ابروش، لانه كان قد في اردي واللينز كانت متغيره. هذه التغيرات اللي يمكن نتوقعها من بعض IOL ريبوزيشن. النظر بيتوقف على التغيرات اللي حصلت في الشبكيه، واحيانا يكون لها علاقه بالتغيير موجود في القرنيه. الريكومنديشن طبعا الانتيرور فيتروكتومي، بروبرلي انتيرور فيتروكتومي بيقلل من الكومبليكيشن. لهذا يعني انا اشوف انه جمعيه العيون تاخذ على يدها في هذا الموضوع وتعمل كورس مكثف حول الانتيرور فيتروكتومي، لانها صارت يعني من كثره عمليات جراحه الماء الابيض والتغيرات اللي تحصل، حتى يقللوا من كومبليكيشن الممكن بعد عمليات الماء الابيض اذا حصل لهم مشاكل. طبعا ما في بعضهم يعمل عدسه ويحاول يعمل عدسه، اذا سقطت ثانيه ما فيش داعي المحاوله هذه، حولوها للاصدقاء وهم بيقوموا بالواجب بكل ساعه سد ورحب ان شاء الله. شكرا لكم، السلام ورحمه الله وبركاته.
كم الساعة الآن؟ كويسين جدا، كويسين جدا. في مقترح من الدكتور إياد إنه المحاضرين الدوليين من الخارج كلا على وقته. Okay. We will start with دكتور ستيوارت. تمام، نبدأ الإنجليزيين أولا ثم المحليين. تمام. Okay. Next speaker is going to be Dr. Alice Stewart from UK. Dr. Alice Stewart, cataract and refractive surgeon at Optegra Eye Healthcare, United Kingdom. Dr. Stewart.
Good morning. At the moment, I can't share my screen because there's someone else sharing.
Place for you.
So I need the person who's controlling the meeting to stop sharing their screen so that I can share mine. Thank you. Brilliant. Can everyone see my slides?
Yes, sir.
Great, lovely. Well, thank you very much for inviting me to speak this morning. It's a real pleasure. So I believe that in refractive surgery for presbyopes, we're at the beginning of a paradigm shift. Multifocal lenses have been the mainstay of lens choices for intraocular surgery for people looking to have glasses independence for many, many years. But they have some well-known and well-documented drawbacks. So those are principally problems with night vision, but also problems with a drop in contrast. So we know that all patients suffer with this. Sorry, I don't know why my pictures aren't coming. Here we are. We know that all patients suffer with this, but we don't know at the beginning which patients aren't going to neuroadapt. And that is really the crux of this, because as the previous speaker explained, when these lenses work, they work beautifully, and the patients are very, very happy. However, there is this group of patients in whom these symptoms never resolve. And in those patients, you're rather stuck between a rock and a hard place, in so much as you've only got two options: to tell the patient just to live with it, or to exchange that lens. Well, exchanging that lens, firstly, is a second surgery that comes with risk, probably more risk than the first surgery. But also, what are you going to exchange that lens for? Well, you're probably going to exchange it for a monofocal IOL. And in doing so, we'll rid the patient of all the benefits that they have had from that multifocal. They'll then need reading glasses. So we've known about these problems for a long, long time, but it feels like it's just been the elephant in the room that we've been ignoring. So this is a paper from some very eminent ophthalmologists, Randleman and Stulting, talking about dissatisfaction after multifocal IOLs. And what I thought was interesting is in the conclusion, they explained that few eyes required an IOL exchange. Well, actually, that few is 7%. So if you counselled a patient at the beginning and explain, look, you've got a 7% chance of needing this IOL taken out and swapped for another one, they're going to be concerned. If we look at this study here, which is far larger numbers from a study in India, they looked at the incidence of night vision problems after surgery with trifocals. And what they showed was that around about 5-6% of patients a year down the line still have halos all of the time. And of a percentage of those, they are severe. And again, you don't know at the beginning who these patients are going to be. As much counselling as you'd like to do, you cannot predict who this is going to be. Now, I'm not saying multifocals are the devil. I use them. In fact, I've got a patient just like this who I'll need to do a lens exchange this month, in whom everything looked great on counselling. Outcome from the surgery on paper looks fantastic, but she's just very, very dissatisfied with her quality vision and her night vision. And I've got no other option other than to do a lens exchange. So there is a new trend that's out there, and that is EDOF lenses. Now, the first thing to really cover here is that EDOF stands for, as I'm sure you're aware, extended depth of field. But that is very much an umbrella term that encompasses a lot of lenses. And it's really important that we understand the nomenclature here. So Jorge Alio did a fantastic paper on just that. And what he spoke about was that the term EDOF should be limited to those IOLs in which a manipulation has been made in their aberrometry. That is to say that true EDOFs are lenses that manipulate spherical aberration. There are essentially two types of EDOF. There are diffractive EDOFs and non-diffractive EDOFs. And I would say that lenses that use spherical aberration induction are true EDOFs, and the other ones that, if they've got rings, are hybrid EDOFs. They're essentially low-powered multifocals. So those are a different side. You are still going to get night vision problems with hybrid EDOFs simply because they are splitting the image, they use rings. So the Rayner EMV lens is an EDOF lens. It extends depth of focus, but it is a true EDOF in so much as it doesn't have rings. What it does is it induces positive levels of spherical aberration. So what exactly is spherical aberration? Well, it's a higher order aberration. It sits here at Z4. And essentially, if you've got a monofocal lens without spherical aberration, all of the rays of light come into one ideally sharp focus point. Now, if you stray away from that sharp focus point, you get a very, very rapid deterioration in the quality of vision. If you take a lens and incorporate spherical aberration into that system, it creates what's optically known as a circle of least confusion. Now, that will give you a nice clear image in the middle. But as you move away from that center, you maintain image quality for much longer. This is the extended depth of focus. This is how this lens works. So there are plenty of other EDOFs on the market, but I believe that Rayner have got a head start and they're a market leader in this because of the way this lens works. And it's because it works with positive spherical aberration. There are plenty of other lenses on the market that use negative spherical aberration. Now, this is why I think that having positive spherical aberration is better. And the reason is it's not just what the lens does, it's a combination of what was already on the patient's cornea. So whole eye spherical aberration after cataract surgery is what's on the cornea plus what's in the lens. So you can't control what's on the patient's cornea, that's innate to them. And we know that innate levels of spherical aberration are usually positive. The standard deviation for human corneal spherical aberration is just over 0.2 with a pretty tight spread. So in my mind, if you're going to give negative spherical aberration to this system, you're going to move the needle back towards zero. So I can't conceptualize how incorporating more minor spherical aberration into the system is going to give the patient increased depth of field. If anything, I would think it would make it less. So I've spoken to lots of people at J&J and things like that who use lenses that are negatively spherical aberrated, and I just haven't yet got an answer that I have understood. With the Rayner EMV, you're pushing the spherical aberration more positive, so you're moving this needle further into the positive, and that's why I feel that that will give more depth of focus. Now, for today's talk, I'm not going to cover these little areas here because that's looking a little bit more in detail about other lenses. We're going to focus just on the EMV today. So really, there are two separate ways of using the EMV. I like to think of using a bilateral emmetropic target, sort of the entry level. So this is the idea of using the EMV with a plano target in each eye. So this is great for surgeons who aren't particularly experienced with refractive options, they're not using presbyopic solutions, because you can start using the EMV at plano, not really have to change anything. You do exactly the same biometry, exactly the same surgery, you just put in an EMV rather than your standard monofocal. Patient's still going to get that brilliant distance vision unaided that you expected, but they're also going to get some useful intermediate. So that depth of focus will allow them to read reasonable print in good light. So if they're doing what I'm doing right now and using a computer, they'll probably do that unaided, but they're going to need reading glasses for the smaller prints. So I've got a case example of someone who had that. So this photo is actually of my children and my parents. And the reason I'm showing this is you'll see that my dad isn't wearing his glasses. And that's because early last year, he developed cataract. He was keen for me to do his surgery, but in the UK, that's very much discouraged. So I asked one of my colleagues to do it for him. So he was a low hyperope. And the important distinguishing thing here is that my dad had developed cataract. He wasn't looking for a procedure to reduce his dependence on glasses. He just couldn't see well enough in his glasses. He's a very stoic gentleman. He wasn't motivated towards glasses independence at all. But I said to him that by having the EMV at plano, he rather had nothing to lose. He'd gain some extra reading without any of the risks of night vision and drops in contrast. So that's what he had. And my colleague did a super job for him. He ended up plano in both eyes. And look at his unaided vision. He's now 20/20 in the distance. That's what he was looking for because he wanted to be able to drive nice and easy. But he's N8 unaided. So what that's meant is that if he's in his house with good lighting, he can read a book, no problems. Sure, if he goes out for dinner and it's dim lighting, or if he wants to read my children a bedtime story and the lights are dimmed, he uses his +1s. But it's conveyed him a huge amount of independence from his glasses. So he tells me that now he can leave the house, and if he's forgotten his +1s, he doesn't go back for them because he can get by. That was certainly not the case prior to surgery. So an emmetropic target in both eyes is a really nice, easy way of conveying some really good satisfaction for patients. But if you're wanting to really go for a true presbyopic solution, i.e. glasses independence, you need to incorporate monovision into the system. And this really is what the lens was designed for. Graham Barrett viewed this lens to be used for monovision. Now, standard monovision with standard monofocals has got some very well documented drawbacks. And this is why a lot of surgeons feel a little burnt by monovision and recoil at the idea of it. So the first issue is tolerance. Only 2/3 of patients tolerate monovision when it's done in a standard way, either with contact lenses or with monofocal lenses. Patients struggle with their intermediate vision, and that's because they've got one eye totally set for distance and one eye totally set for near. So there's nothing covering the intermediate. So what they'll often find is that they either have to come really close to the screen to use their reading eye, or sit really far back to use their distance eye. They also get distance suppression. So the reading eye, in essence, gets in the way of their distance vision. They complain of blurry distance vision. I would refer to this as cross blur. The final thing is stereopsis. So it's been shown that this can reduce patient stereopsis. And if you leave it there for too long, you can actually irreversibly break their stereopsis. Now, when you incorporate spherical aberration into a monovision setup, it's different. It gives you more. I like to refer to this as modified monovision, or some people refer to it as blended vision. It's the same principle as used in Presbyon on a laser platform with Zeiss. So the idea is that instead of with standard monovision having one completely for distance, one completely for near, the spherical aberration gives depth of focus so that the distance eye can do some useful reading. It's helping the reading eye, and vice versa. The near eye has some useful distance vision and will help the distance eye. So in essence, the eyes are working synergistically. And this is what improves on the pitfalls of standard monovision. So I've been doing this for some time now, and I've got some reasonable amounts of data. So this is based on my first 35 patients doing this. So that's 70 eyes. Those are patients that were undergoing bilateral cataract surgery or bilateral refractive lens exchange where there's no cataract. My refractive target was always plano in the dominant eye, and about -150 in the non-dominant eye. And we recorded the unaided visions, the corrected distance vision, their refractions pre and post-op. And we also looked at the corneal and whole eye spherical aberration pre and post-op. And here are the results. I'm very pleased to say, I think they're brilliant. So if we look at glasses independence, well, 71% of patients were 20/20 N5 or better binoculary. That is fantastic results for presbyopic correction. That can stand up against any multifocal on the market. The refractive accuracy was fantastic. 71% of patients were within half a diopter of the intended target, and 100% were within 1 diopter. And the safety was great. Nobody lost any lines, but then you would probably expect that in lens surgery most of the time, particularly in patients with cataracts. The important things was that no patients complained of cross-blur eye. Nobody didn't tolerate the anisometropia. And there were no night vision disturbances whatsoever. But really, these final two are the proof of the pudding. This shows that this lens confers depth of focus to patients. So what we're looking at here is in the near eye, in the distance eyes, what is the unaided near vision? So what's the unaided near vision of an eye set at plano? So if you think of that in a normal monofocal, if you've got unaided near vision of a standard monofocal set at plano, the reading will be lousy. It'll be probably N18, N24. With the EMV, I found the average to be N10. In the reading eyes, now we're looking at, okay, if there's eyes set at -150, what's the unaided distance vision? So again, to use the contrast of a standard monofocal, if you put a monofocal at -150, the distance vision is going to be terrible. It's going to be 2100 at best. Well, in these eyes, it was 2063. That shows that this lens is doing what it sets out to. It is conveying depth of focus to this patient, and that's why it works. So to summarize, I think that we're going to start seeing a drop in the number of multifocals being put in internationally And that's going to be somewhat replaced by EDOF lenses. And I don't think it's going to completely cannibalize it. I don't think that multifocals are dead. They still definitely have a use. I tend to say to patients that multifocals will offer the greatest range of glasses independence possible, but it comes with these rare but potentially significant caveats of night vision and poor tolerance to the contrast. So I find that I sleep better at night for patients that I'm offering EMVs for, because the worst that can happen really is that they don't tolerate the anisometropia, and that I have to use laser procedures to reduce that slightly. Sure, they'll lose a little bit of reading from that, but they will still be able to access that vision with glasses. In the case of a non-tolerant multifocal, you can't just give them glasses to make it better. They've got to go back to the operating room to make things better. So I really see a shift towards extended depth of field lenses. And my personal feeling is that at the moment I feel most comfortable with the EMV because it's the only lens that's patented for a positive level of focal aberration being induced. Thank you very much for your time.
Thank you, Dr. Stewart. Dr. Stewart, we have one question from the audience.
Sure.
Dr. Alistair, can you hear me?
I can, yes.
Okay, thank you. Thank you very much for sharing your experience with us. My question is about dysphotopsia, either positive dysphotopsia or negative dysphotopsia. How long do you observe the patient until you decide to intervene, either by removing the IOL or other method? Thank you so much.
Thank you. Sure. So this I really only would have to do with multifocals. I've not experienced anyone with the EMV that I've needed to do a lens exchange, and I don't anticipate having to. But really, I counsel patients that if they're really struggling, the minimum time I want to get them to is 6 months. Because if we dive in before then, there could have been neuroadaptation that was going to happen. It's a little bit patient by patient, because some patients can be really adamant that they need it doing. So the patient that I spoke about in the lecture, the one that I'm doing this month, we're probably going to end up doing her lens exchange smack on 5.5 months, because she's just so distressed by it. She's finding life really, really difficult. So I know that that patient is never going to get to full adaptation, because they're so bad at this point that it's extremely unlikely that they're going to have complete neuroadaptation in any time frame. So in that situation, I am going to do the surgery a little bit earlier. But generally speaking, I like the patients to get to 6 months before I'm contemplating a lens exchange.
Thank you, Dr. Stewart. Next speaker, we have to apologize for Dr. Hisham and Dr. Adel. Second, and Dr. Mahfoud also, Prof. Mahfoud. Now we are going to present Prof. Aziz Shaher to present his lecture, My Experience with Rayner IOL. Prof. Aziz.
Next slide, please. Is my routine technique in cataract surgery. I'm doing vertical chop and implantation of a tracheal lens under ringer lactate. I'm not using viscoelastic. So there are some advantage for this procedure. So it is short time, as you see can here. It is short operating time. Also, it decreases chance of increased post-operative increase in intraocular surgery. And also the second day, you will find your corneas clear, crystal clear. Also, it is economic. You will not buy viscoelastic. It is easy. انت طبعا بدل ما تبكر يوم ثاني, so the next day you will see your, if you use viscoelastic you have to remove it well, but here where you don't use it, on the next day you will find your cataract is clear, you will find your cornea is clear. So this is my routine case. Let's just see. I show this is my routine, but I bring cases that I use Rayner lenses in senile cataract and in congenital cataract. Get the next, please. Next. Okay, let's show the video. This is vertical chop. This is my routine procedure. شوف الفيديو شو وقف. So I divide it into two. Then as this each half is subdivided into 4 quadrants. Then each pieces I can divide it into small pieces so that I can emulsify it easily and absorb it. As you can see here. Vertical chop is very easy and simple and very safe, because stop and chop you are threatening the posterior capsule. Also, divide and conquer you are see now I do irrigation aspiration. Then now see I'm using the water ringer lactate to implant the intraocular lens. As you can see here, I implant the intraocular lens under ringer lactate or BSS or water without using viscoelastic. See the water's coming out. Underwater also, I dial the lens underwater also. I'm not using viscoelastic. Then you don't need to do irrigation aspiration after implanting the intraocular lens. Just do stromal hydration and finish the operation. It's very short time. This is second case, also senile cataract. I do the same procedure. Vertical chop, as I say, it is easier and safe. It is easier and safe and divided into 2 halves. And then each half is subdivided into quadrants, and each quadrant is subdivided into smaller and smaller pieces so that you can emulsify it easily and absorb it. طبعا I'm not afraid to rupture the posterior capsule. I'm working on the nucleus itself, so I have to do what I want with this nucleus without threatening the posterior capsule. It's vertical chop. It is very nice technique. شوف الآن بزرع under water أنا بعمل irrigation aspiration. And then I will implant underwater. See, I'm implanting the intraocular lens under ringer lactate without using viscoelastic. طبعا اصحاب الشرايك بيزعلوا ان انتم تشتروش منهم فيسكويلاستيك ماتيريال، اكيد بيزعلوا يعني، من ضمنهم جزيره الخليج طبعا الراعيه لهذا المؤتمر يعني. تزعل يعني. See, I am implanting the intraocular lens easily, well centered. I do stromal hydration and the operation time without doing more manipulation inside the eye. This is third case also, and same procedure as I said, vertical chop. You have to grab the nucleus well, and then do vertical chop and divided it into 2 halves. When you divide it into 2 halves, it becomes very easily. الفيديو لو سمحت. واقف. When you divide it into 2 halves, it becomes easily for you to subdivide it each half into 4 quadrants. And then each quadrant it can be subdivided into smaller and smaller pieces so that you can easily, using low parameters of the vacuum, and you can easily emulsify it in such circuit. All these lenses that I implanted in these three cases are Rayner lenses, because I use this technique, all lenses, different type of lenses. But this video that I have shown are Rayner lenses. I'll do irrigation aspiration, simple. Then again, I'm using this is my routine technique. Yeah, I'm using now. See, this, I will see now if I finish my from different side by manual irrigation aspiration. See, I'm using now water. See, I'm using water to implant the intraocular lens. This is very easy and very simple and very safe. You can implant it very easy. توفر على نفسك قيمة viscoelastic. Implant very easy, very simple. Without then you don't need to do. See, I dial the lens underwater. See, I put it in the bag. Yeah, underwater also. I mean water, I mean ringer lactate. Yeah? So I do just irrigation, stromal hydration. I finish the operation. So this is senile cataract cases. So next video, please. I do now in congenital cataract. In congenital cataract, this is zonular cataract. You can see the zonular part in the center. See, this is zonular cataract. Child about 4.5 years. عمل العين الأولى في مدري فين عملها. المهم قال إنه العين الثانية أخروها عشان لما يكبر. نعم. بقى عندي عملت له طبعا capsulorhexis, you know, capsulorhexis, special capsulorhexis in children. So you have to pull the edge of the capsulorhexis toward the center, not circumferential. Otherwise, it will go to the periphery. Now this is the zonular part or the lamellar part. It's not easy to remove it by irrigation Simcoe cannula. So you will do many manipulation inside the eye, and you will get the next day you will get corneal edema. So I use phaco to absorb it, to remove it. See, easily and quick, and without threatening the clarity of the cornea. You know, in the children, it is very. طفل video يا Captain. In children, it's very important, especially in young, to do posterior capsulotomy and anterior vitrectomy. In this case, ماله. In this case, you know, الفيديو ما كملش حق الطفل عشان نزرع العدسة. ايوه هذا عشان نزرع العدسة في الأطفال. It's very important. لا قبلها شوية. ايوه. Okay. Now I do irrigation aspiration in the child. It's hydroimplantation, intraocular hydroimplantation. You have to do clear irrigation aspiration. You know, I'm not doing posterior capsulotomy anterior vitrectomy because he's old. He's about 4.5 years, so I can do YAG laser capsulotomy when I need. So now I finish irrigation aspiration. Now I will implant underwater also in this child. As you can see here, see, I'm using now ringer lactate, and this is the intraocular lens. You know, in children, it is recommended to do suturing for the cataract wand. But here, but for me, I'm not using suturing. I use only stromal hydration. I'm satisfied with this procedure. So I implant now the lens underwater in this situation. So I'm doing now, I dial it into its bag. This case, I'm not using. See, water is coming out in this child, and I'm not using suture in the phaco incision. But it is recommended to do. So لأنه الطفل طبعا حقه elasticity of this. I do only irrigation, stromal hydration, and this work well for me. Next. خلاص next. Thank you very much.
Thank you, Prof. Aziz, for your valuable talk. The next speaker will be Prof. Sai Kole. Professor Sai Kole is a consultant obstetric surgeon based at the prestigious Queen Elizabeth Hospital in Birmingham, UK. He is the lead consultant for cataract and cornea at University Hospitals at Birmingham. Prof. Kole, are you ready? Do you hear me?
Yes, I can hear you. Can you hear me?
جبت زبالة.
Okay, so I'm going to start now. I'd be grateful if everyone else could mute their brilliant. So thank you for this very kind invitation from the Yemen Ophthalmological Society, and also thank you to Rayner for asking me to speak. I'm going to talk about the Ray 1 trifocal lens. So we've talked about the enhanced monofocal. Alistair gave an excellent talk just now. So I'm going to supplement that by telling you more about the Ray 1 trifocal. So patients' expectations are demanding, and that includes the ability to be able to read after lens surgery. And there's increasing demand now that we all see with knowledge of these lenses to deliver complete vision following cataract surgery. As Alistair said, not everyone is a candidate for monovision. Even for good candidates, monovision is still a compromise that will see certain distances that they don't see so well in. And premium lenses, we've already talked about these enhanced monofocals, also extended depth of focus and trifocal lenses allow a better range. And as has been previously mentioned, trifocal lenses represent currently the lenses with the widest range of vision. So the key to success is making sure that you've got the right patients and the right eye. So, so who are the right patients? So patients who've clearly stated in your consultation that they want to be free of spectacles, and in particular that they want maximal spectacle-free vision at all distances, including reading. And as we've spoken about, they have to understand the concept of compromise in this regard. All trifocal lenses, there will be a period of initial dysphotopsia, which in the vast majority settles, and there has to be adequate lighting for them to get to excellent near vision. And the patient has sort of rejected the idea of blended vision, which we've discussed already, and that the eye is normal. So trifocal lenses certainly give the best range of vision in appropriate patients, but the medical bar is relatively high compared to other lenses. The cornea needs to be regular with low high order aberrations. There's suggestions that angle kappa may be important. The macula and optic nerve need to be healthy and normal, and you need to have good ocular surface. There has to be an adequate tear film, and if not, that needs to be assessed and treated before. And as has been mentioned before, the patient needs to be aware that the greater range of vision does come with a slightly reduced, lower quality of vision in low vision situations. So who's a good candidate for trifocal lenses? Normal retina and normal macula. So all these patients, I certainly perform an OCT scan to make sure that this is the case. The normal cornea with low higher order aberrations, they have to have a good tear film and optic nerve function. So who are poor candidates? Well, anyone with retinal or macular pathology, so certainly anyone with an abnormal OCT. So typical things that we may find that's not obvious on clinical examination is sort of epiretinal membranes, early age-related macular degeneration. Any abnormal cornea, so any patient with sort of certainly irregular astigmatism or high order aberrations is not a good candidate. Patients with poor tear film or optic nerve pathology. If these can be assessed and alternatives can be given, you on the whole going to get very good results with trifocal lenses. So the other key is that biometry and IOL calculations for trifocal lenses, accuracy is absolutely key. So you have to use modern barometers with modern formulae, so away from the sort of those formulae which only use axial length and keratometry. So we're using now things like Barrett 2 Universal and the Hill RBF formula, for example, and we need to ensure total correction of sphere and cylinder. So the one take-home point I would give to the audience is that if you're going to have successful, happy patients with trifocal lenses, you need to have post-operative emetropia. The post-op outcome should be close to zero. And in this regard, any astigmatism needs to be treated. So I certainly use toric lenses for any patient with sort of over 0.75 to 1 diopter. And that means that in a significant proportion of my patients with trifocals, I will be using toric lenses. So for those of you who are looking to try using trifocal lenses, the key would be to make sure that in your monofocal patients that you are achieving sort of 6.6 or better with little or no refractive error post-operatively. So with enhanced monofocals, obviously Alice has already shown that the results are excellent for distance and intermediate vision. And the nice thing about those, as he's touched upon, is that they work well even in the presence of a less than perfect macula and cornea. However, in patients with healthy eyes and who understand the limitations, trifocal lenses certainly provide excellent spectacle-free reading vision in addition to both excellent distance and intermediate vision. So what makes Rayner the best choice for presbyopia correcting lenses? Well, certainly in the United Kingdom, we're very familiar with the Ray 1 family. So most of us, so for example, I use the hydrophobic monofocal in my NHS patients. So that's the main lens used I work in a very large teaching hospital. So we're very familiar with the platform. They're easy to use. They have excellent visual outcomes. And so I'm going to be speaking specifically about the trifocal and the trifocal toric. So those are called the Ray 1 trifocals, and it's the RAO 603 or 613 if it's the toric version. So there are other options for multifocality. So a lot of it depends on whether the patient is phakic or pseudophakic. So they do have options where one can place a sulcoflex lens on top of an eye that's previously been pseudophakic, or even use it in combination with a monofocal. So the sulcoflex lens can be removed if patients have dysphotopsia. On the whole, I don't tend to do this. I make a decision in all patients whether to put in sort of an enhanced monofocal, such as an EMV, or a trifocal lens. So, and in all patients with one diopter or more astigmatism, I will use a trifocal toric lens. So just to introduce you to the Ray 1 trifocal platform, for those of you who haven't used it before, it has a large optic with a reasonable overall diameter. It centers very well. And the nice thing about the trifocal toric platform is that the lens is very stable. I've been putting in these for many years, and I've not had to rotate a single toric lens, so they tend to stay exactly where you put them. The optics are aberration neutral, and that means that they are much more forgiving of any slight, if they're not quite central or slightly tilted. They're fully preloaded, so unlike, there's still certain lenses, for example, the Alcon platform, where you have to load the lenses, the entire power range is preloaded. They're biocompatible, although hydrophilic, they're biocompatible acrylic, and they have very little inflammatory response and excellent biocompatibility. The other thing that I've been most impressed about with the Ray 1 platform is I've used a lot of trifocal lenses previously. For example, Fine Vision, when it first came out, used lots of the Zeiss lenses, but the Ray 1 trifocal has marked reduction in the posterior capsule thickening compared to those other lenses. So the paper suggests about 1% at 24 months, which compared to some of the other platforms is pretty amazing. There's zero glistenings, and there's excellent anti-vaulting haptics. So, I know lots of with a lot of other lenses, we tend to always use a capsular tension ring, etc., to prevent sort of vaulting with capsular fibrosis, etc. That doesn't happen with this lens. But the aberration neutral aspheric optic is particularly good at allowing forgiveness of exactly where the lens stays. It's also designed for less pupil dependency. We know that previous generations of multifocal lenses are very pupil dependent. The Ray 1 has fewer rings on the optic surface, and this reduces the potential for visual disturbances and has improved night vision compared to some of the other trifocal platforms, which we'll look into in further detail. There's 16 diffractive steps and rings. The benefit of that is it reduces visual disturbance. The diffractive zone is 4.5 millimeters, so it's less dependent on pupil size or lighting conditions. And there's a greater than 4.5 millimeter distance zone, which increases distance vision in mesopic conditions. So there's excellent light usage. So again, with previous generations of trifocal lens, multifocal and trifocal lenses, was that there was a significant reduction in light transmission. So the light loss was significant, and this used to produce a marked decrease in contrast, which we discuss at length. That reduction in light transmission has been reduced to only 11%. So 89% of the light is transmitted to the retina with a pupil of 3 millimeters. And half of that is allocated for distance, and the remainder is divided between the intermediate and near vision. So it has this very interesting optimized patented diffractive design. So it's the diffractive profile's been designed in partnership with some leading European technology institutes, and they've developed really the most advanced lens they have in their armamentarium at the moment. The diffractive profile is actually consists of two profiles to form the patented design. So you've got the typical asymmetric and the symmetrical designs, and they've been combined to produce the Ray 1 trifocal platform, which is shown there, and that's designed for producing good near vision with a peak at 37.5 centimeters, a plus 1.75 at intermediate, so you've got best vision at 75 centimeters for intermediate vision, and excellent distance vision. and shown there are the Ray 1 trifocal and the toric, and also the Sulcaflex, which we've touched upon. So certainly the four most common trifocal lenses that are used in the United Kingdom are, and this is in order of when they were developed really, the Fine Vision. I've used all these lenses actually. Fine Vision, the Zeiss at-Lisa trifocal, the Alcon Panoptics, and the Ray 1 trifocal. So I've got limited time to go through this, so I've picked out a few important features. So of these, the light loss is the least with the Ray 1 trifocal. It is the only aberration neutral profile. I mean, as I said, the very, very low PCO rate, and the other advantage is it's preloaded and it goes through a very small incision. So again, this is looking at the four main lenses used in the United Kingdom, have how they look, and also that aberration profile, which we've showed the development of that profile there at the bottom right. So again, unfortunately, we've got limited time to go through the peer-reviewed studies. So I have picked up on 4 that have compared the Rayner trifocal lens to the other 3 lenses that we've discussed so far on the market. And to provide a summary of that, we know that there are halos and glare with all trifocals, but fewer patients had halos and glare with the Ray 1 trifocal when compared to the Fine Vision in one study. There was a trend towards better visual acuity in the intermediate defocus group in the trifocal lens. I mean, to be fair, when you look at most studies, they show that trifocal lenses in correct patients produce excellent results. So we're trying to tease out differences. And also the contrast sensitivity was worse in panoptics in higher spatial frequencies compared to the Rayner trifocal lens. So on the whole, the patients in the Ray 1 trifocal lens gave a mean score of 100 for near vision satisfaction. So all of them are very, very happy with their near vision. And it produces significantly better intermediate vision than the Zeiss at-Lisa. So just to wrap up now, how do you ensure success with trifocal lenses? You need to have a thorough patient selection process and align the lens you're going to give with patients' expectations, and that will reduce any risk of refractive surprise. You need to ensure that you have excellent biometry, topography and tomography. You need to assess macular, retina and optic nerve functions. These lenses do not work well in eyes that aren't normal. You need to address dry eye and any ocular surface problems before surgery, and indeed before measuring the eye. Make sure that your surgical technique's excellent, and prior to starting with trifocals, ensure that with your monofocal lenses in normal eyes that you're achieving emetropia in all cases, and you have to be comfortable with addressing astigmatism with toric versions of the trifocal lens, ensuring that you remove any astigmatism will give you great outcomes. But patient education is key. So you want to be honest and transparent. You want to tell them about the potential compromises and certainly over-deliver the results. And when you do this, patients are extremely happy. And I've been using the Rayner trifocal for 3 years, almost 4 years, and I've never had to explant any of these lenses. Patients are very happy. So in conclusion, the Rayner trifocal lens provides increased spectacle independence for the vast majority of patients. And I believe that it provides the best-in-class results and lower aberrations amongst modern generation trifocal lenses. In those patients who aren't ideal candidates for Rayner trifocal lenses, so for example, either there's something slightly untoward with the eye, so for example, they've got very minimal sort of macular changes, or some degree of corneal high order aberrations, or indeed the patient is said, look, I don't want to have any significant glare or halos, then Rayner EMV obviously provides good presbyopia correction in those patients not suitable for trifocals. Thank you for your attention. I've got a couple of minutes for questions, but then unfortunately I've got operating this morning, so I'm going to have to leave pretty soon. Thank you very much. Any questions?
بس announcement بس اللجنه المنظمه بالمناسبه قررت بدل ما تروحوا للكافي بريك هم حيجيبوا الكافي بريك لعندكم على اساس يظل الوقت اللي فاتنا ان شاء الله. لذلك خلاص الكافي بريك حيكون هنا ان شاء الله في القاعه.
ستارز. مش هذا قاعد الحسان. Ray1 spherical IOL implantation. Number three. Yes. Okay. My topic is talking about Ray1 spherical implantation traumatic cataract. Okay. As you know, ocular trauma is the most common cause of blindness, especially unilateral blindness and visual impairment worldwide. About 1/3 and 2/3 of this trauma had cataract, and the most traumatic cataract are intumescent cataract. The classical morphology is rosette or satellite type. There is two types mechanism of forming cataract, either by penetration, you see this laceration and with rupture of anterior capsule, or by blunt trauma by contusion mechanism and forming traumatic cataract. All these types also interfere with visual axis and require cataract surgery. Trauma can affect lens in other by either subluxated lens or dislocated lens, either into anterior chamber or posterior chamber.
All these also necessitate cataract surgery. Any surgery has very surgical consideration. And traumatic cataract, we have focus on type of injury, either blunt or penetrating, systemic health, hypertension, diabetic, type of anesthesia, either general anesthesia or local, corneal laceration, effect of IOL calculation, status of anterior capsule and granules, what time of cataract removal, and IOL implantation or type of IOL implantation. According to the trauma mechanism, with blunt or contusion injury, there is usually intact anterior capsule. Either whether in penetrating injury, there is usually rupture of anterior capsule, and this lead to lens-induced glaucoma and phaco-antigenic glaucoma. Corneal ulceration when present must be first repaired, then cataract extraction removed after 4 and 6 weeks. Except if there is anterior capsule rupture, you must remove it at the repair. Corneal wound is closed by nylon 10-0, and this delay for secondary cataract surgery is for good corneal healing and reduction of inflammatory response. The effect of calculation is in traumatic or larger cornea, there is an accurate keratometry measurement. So most surgeons, based in the fellow eye keratometry, or use an average 44 or 45 in calculating the biometry. The status of anterior capsule and granules, usually you use triple blue to help visualization of anterior capsule to assess its condition and control more easily. In non-ruptured anterior capsule, you have two standard continuous curvilinear capsule excess. Okay, the status also, if there is rupture anterior capsule, if you the continuous curvilinear capsule excess cannot complete, you use venous scissor to avoid avoiding the bridge of the anterior capsule with phaco handpiece or irrigation aspiration tape. In case of zenal weakness, we use iris or capsular bag hooks or capsular tension ring if there is 39 degree of zenal fibers. The time of trauma, as you mentioned before, is there is rupture of globe and anterior rupture capsule. You must first repair of the cornea, then remove with aspiration, irrigation, or phaco emulsification, then put IOL if possible. The time of after penetration is usually after the usually the penetration sometimes is still the wound and the eye is injury and you must do medical treatment. Then after 1 week or 2 weeks you can do cataract surgery. When there is quiet eye, prefer to late procedures. The surgical option is ECC, IOL or phaco, or standard irrigation. I prefer in pediatric cataract surgery. There is high risk of posterior capsule obesity, and so I do primary posterior capsulotomy with anterior vectorectomy under 8 years, or if the child is uncooperative. The IOL implantation consideration is the visualization of posterior capsule is poor. You must do IOL implantation as secondary procedures. Is the bag is complete and good visualization of the posterior capsule. You one piece acrylic IOL. If there is rupture of posterior capsule, you put 3 piece acrylic IOL. When there is corneal laceration, avoid or in young patient to avoid placement of anterior chamber IOL. Aphakia is very has sequelae in patients, especially with traumatic. So with the evaluation of IOL implant technology over the years helped improving the prognosis of the problem. The Rayner 1 aspheric technique, they have the same characteristic of other types familial of Rayner Ray1 as Rayner IOL. They have 2 steps system for make the lens ready for implantation. Also, they have a small nozzle that make easy for implantation through 2.2 millimeter incision. Also, they has lock and roll technique mechanism rule in the lens, so the lens is decrease their size inside the delivery of the IOL.
Sorry, 2 minutes.
Okay. This talking. Open. Yeah. This patient came first one incision, then turbine blue, then adrenaline for, and then venous for remove the anterior capsule. Then aspiration irrigation. Then we imploded the IOL, IOL. This patient is 5 years, so I prefer to do surgical opening of the posterior capsule by surgical capsulotomy, then anterior vitrectomy to prevent TCO, and close the stroma hydroduction. This is the first case. Okay, this is another patient with traumatic cataract with posterior synechiae with an okay. The same steps. We use the needle capsulotomy. Then with aspiration irrigation, we remove the cataract. Then IOL implantation. Also, this young patient, 6 years old, we do also surgical anterior vitrectomy. Next. This with contusion cataract with small pupil. Okay, open. With fusion blue. Then by aspiration irrigation, then implantation of IOL, Rayner 1 IOL aspherical, and the same steps for okay. This is the last case with the traumatic cataract with rupture anterior capsule. You see this anterior capsule is opened. We start open the video. Opening the wall, then by fusion blue, then aspiration irrigation directly. Then we implant IOL. You see the margin of anterior capsule. Sometimes if this anterior capsule is obscure the pupil, I do cutting off the capsule. the same also do the okay. Home message as augmentation traumatic enable most of patients to achieve the satisfaction of useful vision. Not everyone can do this. Thank you.
Thank you, Dr. Hisham. Next speaker is going to be Dr. Adel. The title is How Do We Look at the Materials Manufactured for the Rayner lens? Dr. Adel.
السلام عليكم. بالبداية حابب أتشكر من شركة الراعية الجزيرة والخليج والأخ الصديق محمد الحميري على هذا التنظيم، والشكر موصول لجمعية العيون مثل رئيسها الأستاذ محفوظ مشروع على هذه الفعاليات المتميزة. بشكل عام عندما نختار احنا نوع على UL يجب ان نفكر في الماتيريال ونفكر في الكومبليكيشن اللي ممكن يصير احنا من اي عدسه في تصميم في اختيار نوع العدسه اللي احنا نحب ان احنا نختارها. بشكل عام في العالم 120 مليون عمليه كاتاراكت سنويا تقام، ويعتبر هي اكبر عمليه تقام بشكل عام من ناحيه التعداد. هذه العمليات احنا هذه العمليات احنا نواجه في بها مشاكل كثير كومبليكيشن. اكثر من الكومبليكيشن هي PCO، فلذلك كثير من العمليات يتجهوا الى هيدروفوبيك IOL بسبب الBCO. لكن في معنا كومبليكيشن ثانيه، من احدى الكومبليكيشن اللي هي IOL اوبسيفيكيشن. بشكل عام الماتيريال تتدخل كثير بالاوبسيفيكيشن داخل هذه العدسات. شركات كثير في العالم تتنافس في هذا المجال، من احداهم راينر كومباني للأسبقية في اكتشاف العدسات في عام 1949. لاحظ الدكتور ريدلي انه طيارين الملكية البريطانية اللي كان يستخدم الزجاج في الطائرات من BBMA، فلاحظ ان هذه الشظايا هذه ما تجيبش اي كومبليكيشن داخل العين. فهنا بدأ الفكره تشكيل IOL، وبدأوا صناعه اول عدسه بعام 1949 من BBMA. ماتيريال كثير تستخدم في العدسات. عندما نحن نختار العدسه في كثير من المشخصات احنا نركز عليها. من اهم هذه المشخصات اللي هي ابي نمبر. الابي نمبر واللي هو كروماتيك ابريشن، وهذا اللي يحدد احنا مقدار التشرد في الضوء بعد في العين. مثلا في راينر في معنى الهيدروفوبيك الابن نمبر تبعها 43. النورمال عند الانسان في اللينز العاديه هي عباره عن 47. احنا موجود في معنا عدسات من 37 الى 56. هذه 34 الريفراكتيف اندكس حقها 1.5، بينما الهيدروفيليك حقها الابن نمبر 56 اكبر نمبر احنا ممكن نشوفه، مع الريفراكتيف اندكس 1.4. الريفراكتيف اندكس عند الانسان الطبيعي 1.4. هذه العدسات بشكل عام الهيدروفيليك لينز هي اكثر تجانس مع العين بسبب الوتر كونتنت اللي عندها. لكن هذه الخاصيه في عندنا مشكله جنبها، انه ابيثيليال سيل تتحرك كثير جنب العدسه هذه، ويصير لي احنا BCO عندها بشكل اكبر من الهيدروفوبيك. الهيدروفوبيك هي اكثر مشاكل هذه الهيدروفوبيك، وهذا السبب مش لانه الماتيريال تبعها، لانها هي اكثر عدسه تستخدم في العالم الهيدروفوبيك. في معنا مشكلتين اللي تصير احنا في IOL، الكلاسيفيكيشن عند الهيدروفيليك والجلاسينج او جلاسينج عند الهيدروفوبيك العدسات. الكلاسيفيكيشن معمولا عندنا في عندنا ميتر فاكتوريال كوز لهذه العدسات، لكن بشكل عام هي تحدث اما بسبب العدسه نفسها يصير لها كلاسيفيكيشن، او قد يصير بسبب الامراض المرافقه لهذه العين. في احدى المقالات هذه الاستاذ منصور رحيمي من الاساتذه اللي انا افتخر ان كنت طالب عندهم، كان حالتين اللي الفي كي اتش والديابيتيك، وهذا معمول الكلاسيفيكيشن حقهم يصير بالسنتر اوف ذا اي ويل، وممكن يقع بسبب ايش؟ اللي هي ديبوزيت اوف ذا كالسيوم. معمول لنا الكلاسيفيكيشن اما ان كونسنس او بشكل جرونال داخل العين داخل العدسه. احسن ايمينجينج احنا ممكن ناخذ العدسه اللي هو انتيريور سيجمنت او سي تي، لكن اذا كان سطحي والكلاسيفيكيشن سطحي ممكن ما يظهرش داخل العدسه مثل الصوره الاخيره، ممكن ما يظهرش. هل الكلاسيفيكيشن رابط في الديزاين تبع العدسه نفسها؟ في اكثر المقالات يقول انه اسوسيشن ما فيش ارتباط، ما في الديزاين تبع العدسه نفسها او الماتيريال العدسه والكلاسيفيكيشن نفسه. لكن بشكل عام الدق ليزر ما يفيدش، ضروري احنا نعمل اكستشينج للعدسه. معمول اكستشينج للعدسه مرافق بكومبليكيشن 48% من الحالات يقال احنا ايش كومبليكيشن في الاكستشينج. بالنسبه لللوكالايز كلاسيفيكيشن اللي يصير في العدسات، اكثرا احنا نلاحظه عندما يكون في عندنا بريشر، في عندنا ضغط اضافه الى العدسه هذه، واكثر ما نلاحظه احنا في عمليه الديزيك. الديزيك والديميك تقريبا حدود 9 أو 7 من 10 أو 10% من الحالات يصير لهم هذه المشكله، سواء هذه في الانتر شامبر. البسر شامبر في عمليه الشبكيه بشكل عام عندما نستفيد احنا من الغاز تومبرانت للعمليات. معمولا في ال 100 ميكرون الاول من وفي منطقه الكبسول الريكسس نفسها. لاحظوا انه عندما نقصوا الضغط تبع العين نقصوه من اقل من 40 ملم جيفه، والزمن نقصوه من ساعه الى 10 دقائق، نقص هذا الكلاسيفيكيشن كثير داخل العين. لكنه في اثنين توريكال مطروح لهذه الحاجات، اما ديهيدريزيشن في وسط العدسه نفسها، وبعضهم طرحوا التيوري الثاني اللي هو عباره عن هيدروزيشن اوف ذا بروكليك. الهيدروفوبيك ممكن يصير لهم هذه الكلاسيفيكيشن، وهنا في مقالات كثيره تتحدث انه في هذه العدسه الهيدروفوبيك معمول لنا السطح تبعها هيدروفيليك، وهذا هو اللي يسبب احنا الكلاسيفيكيشن داخل العين. لكن بشكل عام هيدروفوبيك هي اكثر عدسات يصير كلاسيفيكيشن لان هي اكثر عدسات هي مستفاده في العالم اكثر من الهيدروفيليك. هذه النقطه ضفتها انا عند الاستفاده من عندما يكون عنده استريود هيلوسيس نستفيد اقل ما نستفيدش من عدسه السيليكون او الهيدروفيليك، لانه بسبب انه الكالسيوم الموجود في هذه الذرات داخل العين يسبب احنا كلاسيفيكيشن بشكل كبير جدا. هذه الصوره الرقم الازرق اول صوره اخذت الارض بشكل دائري عام 1971. قبل كان كل فرضيه انه الارض كرويه، وهذه اول صوره للارض كرويه، وهي كانت غير محسوبه لها انها تصير بشكل كامل دائري بشكل هذا الشكل كامل، وهي من اقل الصور اللي اخذت الارض بهذا الشكل، وسميت باسم العدسه باسم الكاميرا اللي صورت فيها هذه الصوره. هاي الثانيه كاتاراكت مش للزحل، كاتاراكت لكن بشكل جلاسينينج اللي هي اللمعان هذا هو من الحاجات المهمه كثيرا اللي يشتكي منها المريض بعد العمليه، وهذه قد تكون بعله تجمع فقاعات الماء صغيره جدا عند سب سيرفيس اوف ذا اي او ال. اكثر حاجه احنا نلاحظها عند الهيدروفوبيك، لينز. بيجي البحث عليها في عام 1948 اول توصيف لها. كثير من العدسات يقولون من 11% الى 100% يصل لنا هذا الجلاسينج. تختلف من اجري على شركه الكان كثير بهذا الكا، وصاروا انه تقريبا 66% قريبا او بعيدا يصل لهم هذا الجلاسينج عند عدسات الهيدروفوبيك احنا نستفيد منها كثير جدا لانه البي سي او فيها قليل، لكن هذه المشكلات فيها اكثر. نوع قسموا له جريدنج، معمول الجريد 4 هو 4 ما فوق، اذا في 500 فوق في 2 ملم هذه يكون في عندنا مشكله ظهور عندنا للمريض. في فرضيتين، في الفرضيه الاولى يقولون انه بعله اختلال الحراره التمبريتشر عند العدسه نفسها اختلال يصير هذه مشكله. لذلك نحن نلاحظ فوق كل عدسه في الكرتون تبعها في عندها الحراره اللازمه لوضع هذه العدسه. مثل الراينر هي مكتوب فوقها انها ضروري عند درجه حراره 25 ضروري تطرحها بسرعه داخل العين على اساس ما يصيرش هذه المشاكل. وفي النظريه الثانيه اللي هي اسموتيك بريشر ديفريشن اللي ممكن يكون بسبب ضغط اختلاف الضغط وسط العدسه مع الايكوس.
دكتور عادل 1 مينيت.
في الفرضيه الثانيه للجلاسينينج ممكن يكون بسبب الانفيزيون او ديابيتيك. بعضهم يقول لك انه استفاده من كورنيك يوزنج فروم ذا جلاكوما درابس ممكن يسبب لنا هذه المشكله. وبعضهم يقولوا انه الهاي ريفراكتيف باور بسبب ان العدسه نفسها كبيره او الهاي كارتليج بسبب ان العدسه هنا كل ما كبر حجمها كل ما صار عندنا مشكله. النقطه الاخيره اللي اتكلم عليها انه في عندنا 3 معيارات لمقياس هذه الحاجه. في معنى الفجوه الكوتينج، معنى الكونتراست، في معنى اللي هي سب سيرفيس نانو جلاسينينج تكون ذرات اقل وهذه تعمل تشتت للضوء بشكل اكبر. في معنا 3 معيارات اللي هي كونتراست سنسيتيفيتي وفي اكويتي واللي هي سترينج لايت سكاترينج. لايت سكاترينج هي المهم في هذا الموضوع لانه ممكن يكون المريض نفسه الفجوه الاكويتي والكونتراست تبعه تمام لكن المريض يشكي من في حاجات داخل العين وهذه اللي هي استريليتنج. في معيارات لها ميدوليشن ترانسفير فانكشن يقيس بها السبيشال تقاس بها هذه الحاله. كثير من الاشياء داخل العين تؤثر من ناحيه العدسه القرنيه والفندس وحتى الفيتروس ممكن ياثر بهذه معمولا مع ارتفاع السن تظل احنا بشكل اكبر جدا عند الامراض اللي هو ديابيتيك. هذه المقاله تبع على الديابيتيك تيبان اكثر. عندما يقال احنا كاتاراكت سيرجري تقل هذه بشكل لكن بعد فتره هي تعود وترجع من جديد. في كثير من الدخل في به هذه الكومبليكيشن اكثرها تتدخل في هذا المجال. وشكرا.
Next speaker will be Professor Dr. Mahfouz Bamashmous. His talk is use of Ray 1 IOL in scleral fixation.
السلام عليكم وجمعتكم مباركة. أشكر الدكتور عبد الهادي والدكتور إياد. فين الدكتور إياد؟ حد ينادي الدكتور إياد بس. طبعا عدسات راينر عدسات قديمة جدا وأنا استخدمتها لما كنت في بريطانيا من 27 سنة واستخدمتها أيضا في اليمن من تقريبا 23 سنة. أستغل هذه الفرصة أولا أهنئ زميلي الدكتور نبيل طارش بعيد ميلاده. فأنا زميل الدكتور نبيل من أيام ما كنا طلاب صغار في الحديدة قبل 44 سنة. فين الدكتور نبيل؟ قد روح رايح يحتفل ها؟ طيب كنا نشتي الدكتور إياد يجيب لنا كيكة للدكتور نبيل بس تكملة للبرنامج العلمي. الحالات اللي أنا هقدمها هي حالات فيديو. طبعا الله يرحمها الدكتورة أمال الفاتحة لها. هي اللي كان ماسكة قسم الأطفال والكونجينيتال كاتاراكت. بعد ما توفت رجع الموضوع إلى قسم المياه البيضاء. طبعا هذه هي يا مبارك ما له الكونفرنتيشن حقك يروح ويرجع. هذه هي العدسات اللي حاليا نحن نستخدمها. طبعا هذا طفل أجل عندنا عنده بايلاترال كاتاراكت. على طول الأطفال مباشرة لازم ننصحهم بإجراء اللينسكتومي مع انتيروبيتريكتومي. فإذا كان الطفل عمره أكثر من سنة أو تقريبا سنة ممكن نزرع لهم إيش عدسات. وغالبية الأطباء في اليمن يزرعوا عدسات الراينر للأطفال خاصة أنها معروفة ولها هيستوري طويلة. شغل لنا الفيديو. طبعا البروسيجر اللي نحن نعملها هي كابسولوركسس إذا قدرنا. ما قدرناش نعمل له فانس ونشيل اللينس وبعدين نزرع الانترا اوكيولار لينس في الباك. طبعا بصفة عامة العدسة هذه تدخل بشكل جميل جدا in one go. كل الحالات عمل لهم anterior vitrectomy. بعد ما نعمل لهم anterior vitrectomy نعمل pilocarpine. في مدرستين، مدرسة تقول تعمل لهم peripheral iridectomy ومدرسة تقول ما فيش داعي. أنا من المدرسة اللي تعمل peripheral iridectomy. كل الأطفال نحط لهم خيوط، الهدف من الخيوط إنه ما يفتكش علينا الجرح. ما شاء الله excellent results. حتى تبع البصريات كتب good results. هذا أيام الزمن الجميل. هذا طفل ثاني أجا unilateral cataract، عنده حول وكسل في العين. طبعا الأطفال الريزلتس تبعهم دائما unexpected. طبعا نعمل لهم consent إنه احتمال ما يتحسنش النظر وهكذا. لكن شغل الفيديو. نفس الشيء البروسيجر كابسولوركسس ما قدرناش نعمل irrigation aspiration. بعدين نزرع لهم العدسة دائما في الباك. طبعا في الدكتورة الشقنقيري في مصر، هي من أشهر أطباء البيدياتريك أوفثالمولوجي، تعمل لهم كابسولوركسس بوستيرور قبل ما تزرع العدسة. طبعا هي فكرة جميلة، بس أنا الطريقة اللي تعلمتها في بريطانيا لا، ازرع العدسة بعدين تعمل كابسولوتومي، بعدين تعمل انتيرو فيتريكتومي، نتائجها ممتازة جدا. هذا الطفل بالرغم ان احنا توقعنا يكون عنده كسل، لكن ما شاء الله النظر عنده 20/30. هذه مدينة عدن للي حاب يتذكر ايام زمان. هذا المريض الثالث برضو عنده congenital cataract. فدائما البروسيجرز زي ما قال البروف عزيز هي repetitive، بس انت لازم تعملها ستيب باي ستيب زي ما تعلمتها من اساتذتك او من التكست بوكس. فنعمل كابسولوركسس اذا قدرنا، ما قدرناش نعمل لهم فانس كابسولوتومي او حتى نسموها البير كان، الكان اوبنر. بعدين irrigation aspiration. وقف الفيديو شكل لنا هذا كويس. نزرع العدسة. طبعا هنا في عنده thick posterior capsule. طبعا اللينس هذه يعني للأسف الشديد الشركات الأخرى زي زايس وألكون اختفت من السوق، فبالتالي ما عندنا حل غير نحن نستخدم الراينر. فنعمل لهم برضو posterior capsulotomy و anterior vitrectomy. طبعا زي ما قال الدكتور نبيل، ال anterior vitrectomy is very important, is extremely important. بمعنى صح انه اي شخص يشتغل كاتاراكت لازم يكون عنده جهاز anterior vitrectomy حتى يواجه الحالات اللي تحتاج ايش؟ intervention، خاصة في الفيتريوس لوس. هذا الطفل الفيجن تحسن ل 20/50. طبعا نحن لازم نشكر الدكتور محمد القباطي عندنا في العمليات، هو اللي بياخذ لنا البايومتري في العمليات، لانه الاطفال صعب نعمل لهم بايومتري في العياده، فبالتالي بنحصل على حقيقه نتيجه خبرته الواسعه very good results. طبعا الطفل هذا ايضا نعطي لهم ايش؟ مانجمنت للامبليوبيا. هذه الصوره حق الطفل. مشوارها بعيد صار. وقف الفيديو. هذا الطفل من حالات، وقف الفيديو يا مبارك، رجع الفيديو بس. هذه من حالات الدكتورة آمال الله يرحمها، عملت لهم لينسكتومي مع انتيرو فيتريكتومي. طبعا نحن ننتظر لما يوصل عمرهم 3 4 5 سنوات حسب تفاعل الطفل، بعدين نعمل لهم secondary IOL. طبعا جمال عمليات الدكتورة آمال لا ينكرها أحد، very good capsule. فيري جود. ايش هذا الكبسول اللي بيساعدنا نزرع سالكس فيكسيتد اي او ال. فنحن نفضل نستخدم 3 بيس حقيقه، لكن بعدم وجود كل المقاسات نلجا نستخدم الرينر. شغل لي الفيديو. طبعا نحن نتمنى لما نحن نتموت يجوا زملائنا اللي بعدنا يشوفوا الحالات الحلوه حقنا، يقولوا الله يرحمهم، زي ما نحن نقول دائما لكل حالات الدكتوره آمال الله يرحمها. فنحطها في السلكس. طبعا العدسه ممتازه جدا وقويه جدا، فنستخدم السينسكي نعمل سبورت للكبسول ولا اللينس. وبعدين نزرعها في السالكس. طبعا إذا ما في سالكس نستخدم عدسات أخرى اللي هي سكليرال فيكسيشن أو السكلو. نعمل بريفرال أريدكتومي ونخيط الجرح. هذه بلادي صارت بعيدة جدا. شكرا.
شكرا بروف محفوظ. والآن نأتي إلى نهاية الجلسة. استراحة 5 دقائق فقط، 10 دقيقة الوقت. اللي بيحب ياخذ شوية أكسجين ويرجع أو يفضل في مكانه أهلا وسهلا فيكم. 5 دقائق فقط. شكرا دكتور محمد، شكرا دكتور إسماعيل. Next session
Let's start. Would you please may have your attention, please? Let us start the second session, and we have the first. Let us now with Dr. Shano Sobia, which is working in vision correction. He's vision correction specialist, refractive surgeon, and he's director of Eye Institute of Auckland, and he's senior ophthalmic surgeon in Auckland, in New Zealand. Let us start his presentation, which is Ray 1 EMV early experience and tips and cost perspective. وين طيب؟ He's online. Dr. Sobia.
Can everybody hear me there now?
Yes, you are welcome.
Yep, thank you. Sorry, I'm having a few problems with my video, but I don't think you're missing anything by not seeing me. But I'm going to talk about my early experiences with the Ray 1 EMV. Been very fortunate to be able to use it now for about 2 months. These are my financial disclosures. And just a little bit about me. I trained in the United Kingdom. I was briefly a consultant in the National Health Service before I came to New Zealand for my corneal and anterior segment fellowship. And I've been in both private and public practice for about 12 years. And most of my work is refractive surgery. I mean, I'd consider myself a kind of moderate volume surgeon. I'm probably only doing about 800 cataract refractive lens exchange procedures every year. I think it's very useful to kind of give you a lay of the land as far as cataract and refractive surgery in New Zealand with regards to patient selection, patient payment. We have a public healthcare system which is relatively comprehensive, and we have private healthcare. In public, there's no cost to the patient. Of course, there are longer wait times to access surgery. We're only allowed to do delayed sequential cataract surgery in public, and there's very much limited lens choices. In fact, we're really only allowed to use monofocal lenses. We're allowed to use toric lenses under certain circumstances, mainly having more than 2 diopters of corneal astigmatism. Private and self-funded healthcare, however, it's entirely different. We're usually able to get patient surgery done within 6 to 8 weeks in my practice, and they have an enormous range of intraocular lens choices. However, all of the lens choices and all of the costs related to the lens choices, they're paid for by the patient. Even if the patient has health insurance, the patient has to pay out of pocket to access any other lens apart from a monofocal lens. And of course, with private healthcare, I can perform laser vision enhancement. I can always do exchanges and things like that if necessary. And these are the kind of people I see in my practice. It's predominantly a refractive practice. I'm seeing post-LASIK patients, post-radial keratotomies. A lot of these patients are coming in with dry eye. They have other comorbidities such as macular degeneration. I'll probably perform half a dozen lens exchanges for colleagues every year as well. And typically that patient is a patient who's had a multi-focus lens and they're dissatisfied with the outcome. So I guess you have to ask yourself, what do patients actually want, with regards to their vision? And it's pretty comprehensive. They want most things. They want to be able to read. A lot of these patients who are coming in for refractive surgery want to be able to read without glasses. They want to have, crisp distance vision. They want to have reasonable vision at nighttime. They want to be able to use their computer, and of course their smartphone. And increasingly now, we're seeing more and more of patients' reading is done on digital displays, which in a way is actually a good thing because they tend to be backlit. So you get a bit more depth of focus with that. But, what do they really want? And, despite the fact that sometimes we think they want everything, I think we have to kind of discriminate against what we want to give patients and what patients actually want. So I kind of look at this as having visual quality, which is probably more important to us. We look at patients and their results, and we see that they're seeing 6/6 for distance. They're reading N5 for near. And we're very happy with that. However, when it comes to the patients themselves, it really comes down to visual satisfaction. That's what I like to call it. And this is more with regards to how happy they are with their vision. And typically with refractive patients, it relates to how often they're looking for a pair of glasses. And this is what we don't want to give them. I think we probably talk too much about glare and halos. Any lens is going to give you glare and halos. You're adding another refractive surface into the eye. But the two things I really hate to hear from patients are, my vision is waxy or smeary, or they're getting ghosting. And, ghosting I find typically tends to be really with printed text and almost universally with multi-focus lenses. And I'm very honest, the perfect solution doesn't exist. And both patients and surgeons must learn to compromise. It's a paradox. The more independence the patient wants from glasses, the more compromise they have to make when it comes to visual phenomena. And even more funnily, the more money you pay, the more compromise you make. So typically these are patients who are paying for multi-focus lenses, extended depth of focus lenses. And of course, the patient, the more money they pay, the less compromise they're willing to accept because they're paying a substantial amount for many of these implants. So this is just a small selection of my current IOL lenses that I tend to use, and this is almost exclusively for refractive and cataract patients. I'm a big fan of extended depth of focus and multi-focus lenses, and very occasionally I will use an IC8 lens, and very much like surgery. I think you can get very good results using poorly designed intraocular lenses, as you can get very good results with poor surgical technique. You just get very good at doing it. So when the Ray 1 was released, I was actually quite excited, mainly because it was a non-diffractive lens. And this is what we'd been waiting for. But there's plenty to like about the lens. It's a one-piece lens, and it's got a very nice comprehensive range. It goes up to 4.5 diopters of corneal cylinder. It's preloaded. There's less chance of damaging the IOL. There's theoretically less chance of contamination. It goes through a very small incision, and the injector is parallel-sided, so you don't get any stretch to the wound. Almost exclusively, all the other lenses I use, it's almost always a wound-assisted technique using a Monarch injector. But with this, it fits very nicely in a 2.4 incision that I tend to use. Of course, it has to have a square edge. And the thing I really love about the lens is it's incredibly stable. It feels like a big lens, but it's only 12.5 millimeters in diameter. Okay, I'll very briefly show you the video here of the loading of the EMV. Hopefully it won't take too much time. And I can speed up a little here. But, you know, 90% of the job has been done for you. We're very fortunate. Our nurses load all of our lenses for us. They have the lens ready by the time we're doing irrigation and aspiration typically. And this is the main bit. This is the viscoelastic, and you really do not need a lot. I'll talk about that later. You get a nice palpable click when you close the lens. And injecting. Once again, fantastic lens, goes through that a 2.4 millimeter incision very easily. Definitely do not wound assist this lens. It opens up nice and quickly, unlike some hydrophobic acrylic lenses. And it's once again very stable. And what else is there to like about this lens? As I mentioned earlier, it's non-diffractive. So you don't get glare, you get no halo, you don't get ghosting. There's minimal, if any, reduction in contrast, which once again, with increasing spherical aberration, theoretically, you are going to lose a little bit of contrast, but depending on underlying conditions such as macular degeneration and glaucoma. But what I love is, you know, patients don't complain about having waxy vision. You also get very few dysphotopsia because you've got less light bouncing around inside the eye. And all of this adds up to less chair time when chatting to the patient about their lens options. And it's enhancing monovision by the simplest method. You might think you're taking a step backwards, but it actually works incredibly well. You're increasing spherical aberration centrally, but not peripherally. So in low light conditions, you're actually going to get a very good result. And we found, and it fits with the data that Rayner have, we're getting about a +1 to +1.5 add. And there's also this lovely large landing zone. So in post-refractive patients, once again, I'll mention that later, but also in patients with slightly aberrated corneas, you've got this huge area of effectiveness. The other thing is, from the pricing point of view, it's very, very attractive. Your local Rayner representative will be able to give you more information on that. And I'm going to talk about the pricing a little bit more later on. So, you know, this is my early experience. You know, I've only put in about 20 lenses now. But initially, we started purely with patients with cataract. They've been over 65 years of age. Some of them have had comorbidities, ocular comorbidities, including some dry eye, ectropion, mild macular degeneration. I deliberately chose patients who didn't really want, you know, didn't have huge visual requirements. And I also deliberately chose patients that had pre-existing corneal astigmatism. And this is back down to the pricing. Our price point actually for the Ray 1 EMV here in my practice is it's the same as a toric monofocal lens. So I don't need to charge the patient any more money than a toric lens. And they're getting this extra near add. So, you know, who was one of the first patients I put the lens into? It was actually my GP, and he's very happy with the results. He's actually a high myope. He's got a bit of myopic maculopathy, but he's got nice, clearer distance vision, and he's got good intermediate. He can use the computer more than comfortably. I'll talk a little bit about the injector. It's a lovely injector. It's smooth. It's one-handed. You can use your other. You can use the other hand to hold the eye steady if necessary. you really only need to use minimal viscoelastic. Initially, we were using far too much. We were opening up additional tubes, but you can do this actually very easily with a pack of ProVisc or DuoVisc as we use here. Do not wound assist. Definitely do not wound assist this lens. I would be interested to hear from Rayner with regards to how we reinsert ejected lenses. I think we can use the Viscojet system, but thankfully it's not been an issue just yet for myself. So look, this feels like a big lens, and to me that's actually, it's reassuring. It's only 12.5 millimeters in diameter, but it feels much larger. It's incredibly stable. I'm not a huge fan of plate haptic lenses, but plate haptic lenses rotationally, they're much more stable than my usual go-to toric implants. But I found that with the Ray 1, it's equally as stable as those plate haptic lenses. You know, you may say it's hydrophilic. I truly don't believe that's a big issue. It's got a nice square edge. Once again, hydrophilic, hydrophobic, we probably over-exaggerate some of the concerns we have about hydrophilic lenses. One of my tips, watch the toric markings. The toric markings are very visible, but the toric markings are not where I was expecting to find them. They're not on the central lens axis. You know, the green line actually shows the central lens axis, and the toric markings are about 40 degrees off. So intuitively, you tend to want to rotate towards the middle of the haptics, but the actual area of toricity is a little bit further away from that. I think you do have to be slightly careful with post-refractive patients, particularly with patients who've had hyperopic LASIK. That these are patients who've already got, you know, minimal spherical aberration in their cornea, if any, and I'm not sure how much more the Ray 1 will provide. I don't see it being too much of an issue in post-myopic LASIKs, and of course in virgin eyes, you're going to get a good result. If you're able to, I think using aberrometry to see just how much aberration there is in the cornea is going to be very useful. And these are my early results. I mean, there's only 20 eyes, and this is in the last 2 months, but I can see myself using this lens more and more. All of our lenses were barometry, was done using the Barrett formula on Lenstar 900 now, on Master 700. We've got less than 8 weeks of follow-up, but the results have been good. You know, the post-op spherical equivalent is close to 0. Unaided distance has been between 6.48 and 6.7.5. And the near, this is actually the best bit. The unaided near for patients that we were targeting, you know, essentially ametropia, or as we were instructed initially, go for the first plus. They were getting N8, you know, really quite comfortably. More recently, we have been offsetting the lens slightly, and you know, I think this would work fantastically in patients who already have some monovision in their current prescription. But we're getting these patients down to N6. We had one down to N5, and you know, more importantly, back to that visual satisfaction with the patients. You know, these patients are very happy with the results that they've had so far. This is Fiordland in New Zealand, and this is where I'm going to end my talk. I thank you for listening. I will do my best to stay till the end to answer any questions, but I always put my email up here. I'm more than happy to chat to any of you about my experiences with the implant.
Okay, thank you very much, Dr. Subay. Any question to Dr. Subay?
Hello,
Dr. Shano, can you hear me?
Yeah. Yes, I can hear you.
Yeah, thank you for sharing your experience with us. I'm a glaucoma specialist, and I'd like to ask you Do you think of implanting any other monofocal in glaucoma patients, especially they're having peripheral vision defects?
I would always be careful about implanting. I've never used a multifocus. I would not use a multifocus in a glaucoma implant in a glaucoma patient. Some of my colleagues do. Even extended depth of focus lenses, I'm a little bit tentative. That you can potentially, if you increase spherical aberration too much, you're going to lose contrast. And early glaucoma, I actually think it's a good lens to use. I think it's actually perfectly reasonable. Advanced glaucoma, and I see a lot, and it's the same for macular degeneration. Macular degeneration, I'd almost definitely go for a monovision lens. I haven't had much experience with Rayner, the other lenses in Rayner, apart from the Sulcoflex. I've used plenty of Sulcoflexes in the past. But when it comes to comorbidity, I'm probably a little more cautious, because another large proportion of my practice in public anyway is retina, is medical retina. So I'm quite conscious about making sure these patients actually have the best possible distance. And I won't use monovision, I won't use blended vision. And typically I won't use a lens that's going to reduce contrast too much. But early glaucoma, I think it's a good lens to use.
In early glaucoma, but in advanced you don't recommend.
I wouldn't recommend anything other than a monofocal in advanced glaucoma.
Okay, thank you so much again. You hope we can have you again in our conferences. Thank you so much. Thank you.
Thank you very much for the invitation.
Dr. Ahmed Bilal, can you hear us?
Yes, I'm with you. Assalamu alaikum.
Thank you. Dr. Ahmed Bilal is an associate professor, glaucoma and cataract consultant, Department of Ophthalmology, King Fahd Hospital. We thank you for your contribution with us today. You can start. Thank you so much. Ray 1 EMV experience, results, and practical use. Thank you so much. You can start now. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be with you guys. أتشرف فيكم جميعا وفي إخوتي من اليمن. جمعة مباركة عليكم. So we'll talk a little bit. I know you're a little bit short in time. So we'll try to tackle the points quickly. I think that was covered, as you know, that Rayner lenses started very early on, and their R&D developed a different type of lenses through the year with different platforms. Today we'll be focusing more on the Ray one, the regular monofocal, and we'll touch a little bit on our experience on the EMV. So I have been using the Rayner platforms for the last 10 years. I tried most of it. I tried the monofocal hydrophilic, the hydrophobic, and the toric, and the EMV, and the trifocal, with even the EMV toric. So our experience through the last 10 years were very successful. I have a private practice in Maghrabi Eye Hospital. I think you also have that in Yemen, which is a very high volume practice, and also in our university practice in the eastern province of Saudi Arabia. We touched on that, so for the sake of time, as we know that it has a 1.8 millimeter nozzle, which fit very easily through the incision, and the previous colleagues talked about not to do it as a wound assisted, and this is very important to provide any errors during injection of the lens. It really rolls up in a very nice fashion and make it very easy during insertion of the IOL in the bag, with less chance of damages. And this is the nozzle that goes very nice. I usually go with a 2.4 or 2.2 millimeter incision. It depends on what's available in the table, and it fit really nice in this type of incision. This is a quick video. I usually, what I do, I inject BSS first, just to hydrate it, and then inject a little bit of viscoelastic. It does not matter what type of viscoelastic, you just need to enter a little bit volume. So I usually use one vial in my whole case for inserting the IOL. So as you can see, this is not my video. I'll show you more about my videos. This is from Dr. Barsam from UK, how the injection of the lens goes in very smooth fashion. So the design, they talked about it, our previous colleagues, and as you can see that it has a very low percentage of PCO rate because of the square edge and zero glistening through the studies. What's nice about the hydrophilic lens from Ray-1 that it has a huge volume variety of powers, which is start from -10 to plus 34, which is very useful in our practice because we see a lot of high myopes. And to avoid using another brand for 3 pieces, because it's very rare to have this -10 range of lenses. And you can see the different stages and stability of the lens throughout the intraocular procedure. And this was touched on also, that the lens has a 12.5 millimeter overall haptic, and this is the 6.0 optic zone diameter. And this is very important to know. This is the square edge here, showing the less reduction of posterior capsular opacification rate. And what's important about, as we know that it's a aspheric lens, and you can see that the rate of tilt and this or off visual axis, it's very rare to having it with the Rayner lenses. And comparing with other aberrative negative intraocular lens, you can see even with a little bit of off axis, it does not affect the quality of image and give you a very good quality. And I never had a patient that complains of negative dysphotopsias or some wrist or any of these problems. I usually use a lot of different type of lenses from Alcon, from different lenses, but Rayner, we did not face any problems with these patients. The discussion that usually happened between the yellow filtered lenses and the clear lenses, to be honest, there is nothing proved. Having a clear lens can help in maintaining circadian cycles and the mesopic light loss. So I think the discussion that usually people discuss yellow and white filter does not make a difference, to be honest. I'll just show you now. We'll go through, because of the sake of the time, I'll just go through different procedures. This is a case. I'm a glaucoma and cataract consultant. So our cornea colleague called me for a VIP patient that he will do a DMIC to do a cataract extraction and combined with his DMIC. And as you can see, we did the cataract smoothly, and then we inserted the Rayner hydrophilic lens, and then our cornea colleague did his DMIC procedure. There is no any, I think, contraindication to do a combined procedure. We know that there might be a risk of opacification, but with good hydration of the lens, I think we did not face that. This is also had a hard cataract case that we did with the hydrophilic lens. And the platform is really stable, even with these weak zonules, lenses. We really have a good outcome. I think this is not a scope of showing the technique with the hard cataract cases, but I would like to show you how these lenses fit in very nicely in the bag. This is a mature cataract that we did for him, a vertical chop. We don't want to spend a lot of time. So after a good cortex cleanup, this is the lens coming in and fitting very nicely. The last thing you want things that happen after doing a complicated case to have a problem with your IOL and start struggling. You already have much of stress during finishing the case. So it's very important to have a nice delivery system and a stable IOL. Also, as we know, in posterior polar cataracts, this is one of our cases, and this has been a long time, like 6 or 7 years ago, with a good outcome for the, that we have a really weak posterior capsule. So even the delivery system in the Rayner did not have any problem while delivering the lens. As we know that the posterior capsule can open with posterior polar cataract any time during until the end of hydration. You need to be very careful. So after removing the posterior polar cataract, you know that we need to be very careful, avoid shadowing the chamber during removal of the cataract. After removing the lens and good cortex cleanup, the IOL comes in very smoothly, and it's in a good matter. So as we said, in these complicated cases, the last thing you want things to have any as you know, I'm a glaucoma consultant, so I combine it with different type of procedure. This will be presented next month in the ACRS, combined micropulse laser procedure with cataract. So I used, in this case, he had the one-eyed. This is the one-eyed patient that had the micropulse laser with cataract extraction. As you can see, this pseudoexfoliation, very bad cataract. We need to put a Maillot ring. So it was a little bit a complicated case, and I chose to have the Rayner lens. So after removing the cataract, and a good cortex cleanup, the lens comes in very smoothly, as we see, and it was delivered nicely in the bag. There is no any contraindication of putting a capsular tension ring after putting the Rayner lens. And although it's a little bit, it seems to be big, but you can still put a capsular tension. As we can see, it can go very smoothly around the lens to stabilize the bag. As we can see, this patient had a little bit of 3 clock hours zonual dialysis. So the capsular tension ring fitted very nicely in the bag. This is also another case that was a bit complicated, and the capsular tension ring was inside. And just for a change, this is a hydrophobic lens. I'm not sure if it's available in your market, but as you can see, this is the hydrophobic lens. with a notch here, and it was implanted easily, even with a capsular tension ring in the bag, and with a good post-operatively outcome stabilization with a long term. These cases are has been now for 3 or 4 years. Cataract surgery, just to shift gears a little bit and shift of the lenses. The Rayner hydrophilic lens fits very nicely in our practice in different types of diseases with glaucoma, retina, cornea. So there's no any contraindication using this type of lenses. Shifting gear to the EMV lens, as we know that cataract surgery is a cost-effective procedure. So what's important about it is to have a good visual function, safety, quality of vision, functional vision. It's very important. The aim here is our patient, his satisfaction. I have been doing a lot of trifocal, bifocal, blended visions. So we'll talk more about EMV. We face a different type of patients, the professors, the drivers, the doctor, the players. So we have a lot of range of patients. So everyone needs vision in a different way. So it's very important to talk with your patient, know what's his needs, what does he do through the day, know his personality very well before deciding to choose his lens. We have different needs. We have the near need, the intermediate, and even the distance. So it's very important to try as much as possible to have good vision in all distances without compromising the vision. So the Rayner EMV, the enhanced monovision or extended range monovision lens, shares a very good idea that was described by Graham Barrett, using the dominant and the non-dominant eye, making the dominant on a 0 diopter target, and the non-dominant, it depends on the patient need. What I usually do is giving him a -1 or -0.75 diopter vision in the non-dominant eye to try to blend the vision and to have a good visual outcome. So I have been using the EMV lens now for around 9 months. We had around 40 or 50 patients. It's very important to spend some time with the patients to obtain a good results, having a good biometry and good scan and test. If you're hesitant using one biometry, use 2 or 3. I'm a little bit an OCD regarding these calculations. So it's very important to have a good calculation before deciding the number of the lens. And also I know the patient's expectation before considering that. This was now more than nine months ago when we started the EMV lens. So I'll just, before ending up the talk, I hope that I did not take much of time. This is a case that I had a VIP patient. He's a 40 years old CEO of one of the big petrochemical company. He's very active in sports, traveling, night driving, and he had posterior subcapsular cataract in both eyes. And as you know, these are usually type A personalities, very difficult to deal with. They have high demands, and they can't have any errors post-operatively, because you will find them every day in your clinic. So, and he was a bit of a lucky myope also, that we call that he has a good vision, near vision with a -1 diopter. So after discussing all the options, the trifocal and the EMV, we decided to have, as we said, the dominant eye with a plano EMV lens, and the -1 diopter with an undominant eye. Alhamdulillah, successfully, we had a really good result with this patient. It has been now around 7 months. He's very happy doing his work, reading his computer, reading his mobile, doing his sports. So I think this was the best option for him. choosing this lens. So I would like to thank you all. You can reach me. I'm happy to answer your emails if I'll be until the end of the talk. But if you have any question, I'm happy to answer it.
Thank you, Dr. Ahmad, for this wonderful presentation. So, any question to Dr. Ahmad?
Thank you, Dr. Ahmad. My question is, what is your best lens, Rayner best lens in patients with keratoplasty?
I think keratoplasty, usually our cornea colleagues, if they refer some of the lens, I don't think there's a problem using EMV or the regular hydrophilic lens, but usually these patients have astigmatism, so whatever you choose, it's very important to correct his astigmatism. طبعا the trifocal for me I don't think it's a choice in post keratoplasty. It depends on the corneal sphericity and the Q values and these things.
Thank you. Any other question? Okay, thank you very much, Dr. Ahmad. Hope to see you again.
Thank you so much. It's a pleasure.
حسن دكتور حسن المحبشي.
نعم.
المحشمي، دكتور حسن المحشمي.
نعم.
Yes, you are welcome to our presentation. Please, you can present your subject, please.
Okay, sharing my screen. Clear now? واضح؟
It's okay.
اوكي. بسم الله الرحمن الرحيم. شكرا جزيلا لزملائي في جمعية العيون اليمنية وكذلك شركة الجزيرة والخليج على دعم هذه الفعالية العلمية. My topics is about my experience with Rayner IOL implantation in pediatric cataract. Pediatric cataract surgery is evolving with advance in microsurgical technique. Currently, there is an increasing trend toward IOL implantation in children, with increasing evidence of better visual outcomes in infants managed with IOL implantation. The accepted minimum age of IOL implantation is 1 to 2 years. Now, more surgeons, including surgeons in our hospital, are implanting between 6 months and 1 year, especially in unilateral cataract. Implanting IOLs at less than 6 months of age is still controversial and under study. Treatment of pediatric aphakia is one step on the long road to visual rehabilitation, not the end of journey. Protocol of IOL implantation for pediatric cataract surgery in Al Basar International Foundation, Makkah Eye Hospital, Sudan and Yemen. Makkah Eye Hospital, Khartoum is considered the main reference hospital in Sudan. It provides eye services for an average of 1,200 patients per day. 20 clinics containing all subspecialties, including 5 clinics in pediatric and squint department. The complex containing 7 operating rooms and an average of 150 surgical procedures per day. Since 2006, our center started to use Rayner IOL as a protocol in pediatric cataract. First, I started deal with Rayner IOL in December 2014 during the training period attachment in the pediatric and squint department. Since I joined Al Basar International Foundation, till dated around 9 years, more than 15,000 Rayner IOL implants have been performed in our center for children of age group from 6 months to 12 years. Around 17 years experience and more than 30,000 pediatric cataract surgery with Rayner IOL implantation in Makkah Eye Hospital, Khartoum. Why Rayner IOL in pediatric cataract? Rayner IOL are approved for all pediatric cataract surgeries in Al-Basr International Foundation for the following reasons. High quality product. Our center has a long accumulated experience and large number of Rayner IOL implantation with excellent result. It was observed that Rayner IOL implantation resulted in well-maintained centration, minimum inflammation, less severe BCO, and was well tolerated in pediatric age. Rayner IOL support the current practice that recommend the use of single-piece IOL in pediatric cataract due to the flexible haptics and excellent memory. Something problem. الصوت واضح؟
دكتور حسن.
الصوت واضح؟
ايوه واضح.
Okay, I will continue. Implantation of single-piece Rayner IOL is not technically challenging. It does not deform and adapts to the small capsular bag without decentration. Minimum iris capture and uveitis inflammation, and reduce the migration of lens epithelial cells from the equatorial zone into the central posterior capsule, so less severe BCO. Other advantages of Rayner IOL: easy to use with minimal learning curve and minimal error, efficient IOL delivery system, smallest fully preloaded injector nozzle, about 1.65 millimeter, can be implanted through a micro incision, about 2 millimeter micro incision, to decrease the need of corneal wound suturing. Single-handed plunger with minimal force required, fully enclosed cartilage with no lens handling, so minimal chance of contamination. It is the last case of cataract surgery done before 4 days ago in Haya Eye Hospital Al Mukalla. Please, I will share the video. Sorry for the quality of video. First step is corneal incision, then staining of the anterior capsule, viscoelastic. Now, one of the most challenging steps in the pediatric cataract is capsulorhexis. Due to the high elastic and thin anterior capsule, and the control of rhexis is very difficult and need more experience. Now we continue the capsulorhexis using capsulorhexis forceps. Lens aspiration. As you see, there is thick posterior capsule. Now is the time of IOL injection using Rayner IOL. As you see, it's totally preloaded. The incision is about 2 millimeter. It's well maintained, well centralized. After IOL implantation, I will start the primary posterior capsulotomy. It is very important in pediatric, especially below 6 years, using the anterior vitrectomy cutter to do the posterior capsulotomy. Then anterior vitrectomy is very important step. Now you should clean the AC from any remnant of the vitreous. To be sure, I will inject triamcinolone in the AC for any minimal remnant. Now this is the size of the main incision, exactly 2 millimeters. It decreases the need for suture. The suturing in pediatric cataract, almost the younger patient, and more need for corneal suturing. Now it's the last step in the video. How message? Our observation suggests that Rayner IOL implantation can be done safely in children older than 1 year and even in children older than 6 months, especially in unilateral congenital cataract with no other contraindication like microphthalmia or other structural abnormalities. Post-operative visual rehabilitation, especially in aphakia, is a challenge in the pediatric cataract, especially in our community due to uncooperative parents and child. So visual recovery include IOL implantation in children older than 6 months is recommended. The optical correction of aphakia in children has changed dramatically. However, accurate optical rehabilitation and post-operative supervision in pediatric cases is more difficult than adults, and the majority end with deep amblyopia. This challenge can be reduced by high-quality IOL implantation like IOL Rayner or Ray 1 IOL implantation. We don't recommend to use the other type of IOL implantation in children, especially that available in the local market with low quality. Thank you very much for attention.
دكتور اياد 15,000 عدسه في الدكتور حسن في المكلبات ما شاء الله مش منقر يعني، لكن يوقع مؤتمر ثاني قريب ثاني غداء عشاء يعني.
Okay, next presentation, Dr. Abdurrahman Hamadi, which is my experience in Rayner Premium IOL as a vitreoretinal surgeon. Welcome, Dr. Abdurrahman.
بسم الله الرحمن الرحيم. شكرا للجميع. حقيقة as a vitreoretinal surgeon I need an easy lens to insert and remove, optimum loading and less PCO. This is a series of videos to enlighten some points that I need to highlight it. This is the normal phaco for me. This is the case of macular hole. طبعا يعذرني الجميع على سرعة الفيديوهات لأنه حقيقة الوقت ضيق جدا. This is the good irrigation with the polishing of the anterior capsule. ميزة البريمير lenses as this lens إنها one go insertion، ما تحتاج تعمل أكثر من this is the optimum view for me. This is the entrance. خلاص الآن حدخل لل posterior segment. This is me. What about you? الحالات حتجيلي أصلا منكم. مشكورا أحد الزملاء محول لي الحالة هذه، زارع لها عدسة بريميوم. So I can manage inside. الفكرة مش فكرة الحل اللي عملتها أنت الآن بس، أنا أدخل بعدك خاصة في الديابيتك patient. This is a diabetic patient. شايفين الممبرينز الصغيرة جدا. الفيديو مسرع لكن capsular opacification, soft cataract. All of these are challenges in the phacosurgery of the Fuchs cases. Also, this is an irrigation, aspiration by the coaxial instrument. You see the posterior capsular opacification of this case, which is Fuchs. Also, the premier lens is inserted in one go way also. In Fuchs, also I need to enter the posterior segment to do the vitrectomy, removal of the membranes like this. If there is a bad quality of lens, I can't do this procedure. Yesterday, I saw one case with totally opaque IOL. So I should remove the IOL first and enter to the posterior segment, then reinsert the new IOL by another mechanism. I heard there is some kinacort and air fluid exchange, and then finalization of the case. All of these can be done except if there is a very nice lens. This is the posterior capsular opening by the cutter. The lens is very stable. I do opening because the chance of BCO in this young Fuchs patient is very high. I do opening for the posterior capsule to avoid the next TIAG laser. This is the finishing of this case. The second case is the posterior polar cataract. Also the usual steps. the rexes must be less than 5 or less slightly. Multiple hydrodelination, not dissection, to avoid the opening of the weak posterior capsule. If you do this, you can eat it very well, and by layer, this is the nucleus comes out, and I can remove it. This is the last layer. Please keep pressurized by the visco to avoid the opening of the posterior capsule. This is the gentle IA. على فكرة ال IA gentle بس السرعة مش gentle خالص طبعا. ال posterior capsule needs some polishing around the weak area. Then the IOL is inserted. So you can do the one-piece lens in posterior polar cataract with very good result, especially if there is no opening of the posterior capsule, or if there is a very small opening and you can do vitrectomy. This is the case of glaucoma also.
We have 2 minutes, Dr. Abdulrahman.
With cataract. I use the red reflex to make the rexes. Very challenging rexes in the glaucoma cases and in the cases with weak zonules. So I did small rexes. Then I'll do visco dissection, not hydro dissection, to put the CTR. Okay, now it's better. I'll do some hydro now. I'll do my phaco. This is the irrigation aspiration step. You can see that the bag is inflated well. This is the limited vitrectomy at the site of glaucoma because some of the vitreous comes out. I'll insert the IOL also here by multi-stage insertion because of a small opening. I put this haptic intentionally at this site to support the weakest area. This is some of the Kinacord to trim the remaining vitreous, which is prolapsed. This is the end of the case, which is, well, alhamdulillah, very well.
We have 1 minute.
Case.
We have 1 minute, Dr. Abdulrahman, 1 minute.
Okay. This is that an iridoplasty plus cataract. The mission for you that we can use the single piece lens even in complicated cataract. If you have the number of the 3 pieces or something, you can use it, but you can use it with a very good technique and a very good decision. The posterior capsule here is opened. I make a getter for the suturing, and I remove the مشي الآخر. Okay. طبعا opening superior, so I can insert this lens and do more procedures. I make some vitrectomy. So the whole message is, if you put a very good premium lens, it's good for you, for your patients, and for me as a vitreoretinal surgeon need to interfere for diabetic patients or to do multiple procedures like laser or something. So please don't hesitate to use premium lens as you can. Thank you.
Next, دكتور محمد الشكيل. لما يطلع الدكتور محمد الشكيل بالنسبه للميلز فيها انا يعني مصلى صغير بياخذ يمكن 30 واحد، ان شاء الله ممكن نصلي جمعه. دكتور عبد المغني البراق يدي لنا 10 دقائق عشان ما يروحش علينا الجمعه يعني. وكمان الدكتور اياد توزيع السحب يعني هيتم بعدها على طول.
طيب، بسم الله الرحمن الرحيم.
تفضل دكتور محمد الشكيل.
تحدث عن الفيكو تشوبينج. المحاضرة أساساً للأطباء المبتدئين جراحة يعني. فتفضل. طبعاً معنا two approaches for chopping, either horizontal أو vertical. vertical دائماً يكون من أعلى ليش الكاتاراكت، أما الهوريزونتال يكون من الإكويتر. تفضل. ننتقل مباشرة للفيديوز من البداية لو سمحت. طيب، بالنسبه للووند فورميشن ممكن نبدا بالمين ووند فيرست. طبعا نعمل له 3 ستيبس، واحده فيرتيكال، هوريزونتال، وبعدين فيرتيكال. ممكن نعمل كمان الخطوات الاولى يعني اللي هو الكابسول ريكسز، ونعمل فيسكو، وبعدين نعمل سايد فورس او نعمل السايد فورس مباشره. طبعا بالنسبه كجراحين مبتدئين يفضل انه يعمل فيسكو ثم السايد فورس عشان ما يطلعش منه ليش الفلويد. بعد كده نعمل الستيننج. طبعا بالنسبه للحالات الفيرتيكال تشوبينج ما يحتاج ان الكابسوركسز يكون فتحته كبيره، لان احنا يعني من فوق ليش فيرتيكال. اما بالنسبه للناس اللي يستخدموا الهوريزونتال تشوبينج ضروري يكون على الاقل 5 ملي او اكثر الكابسوركسز. طبعا في معنا طريقه للكابسوركسز، ممكن زي ما شفنا ممكن نستخدم الفورسبس او ممكن نستخدم السيستاتوم. بالنسبه للروتيشن very important في حالات الفيكو عامه، في حاله الفيرتيكال تشوبينج. طبعا اول شيء في الفيكو نشيل الابينيكوليس اللي فوق فوق اللينس او في السطح في اعلى اللينس، ثم بعد ذلك ندخل بالشوبر في النيوكليوس. نبدا طوالي من بعد الكابسول ريكسز، ثم نستخدم السكند انسترومنت اللي هو الشوبر او الدايلر، ونعمل الفيرست كراك. هذه اهم خطوه، هو كيف نسوي الفيرست كراك. ثم بعد ذلك ممكن نكسر النيوكليوس اكثر من قسم، او ممكن انا افضل ان انا اشيل اول كوادرنت عشان يعمل لي مساحه، ثم بعد ذلك اكسرها واشيل على واحده واحده زي ما احنا شايفين الان. طبعا الفكره بالنسبه للفيكو ما نعمل باور او الا اذا كان في معنا اوكلوجن. اول ما نسمع صوت الاوكلوجن معناها انه التب تبع الفيكو مسدود، وبعد ذلك نعمل الباور. ما يحصلش معنا كورنيال اوديما نتيجه الباور، يكون فقط الباور فقط على على اللينس ماتر اتسلف. بعد ذلك طبعا اكثر خطوه واهم خطوه هي اللاست كوادرانت، لانه ما عندنا سبورت من اللينس للبوستير كبسول. طبعا في معنا طريقتين او يعني او اكثر من طريقه لازاله الابينيوكلياس، احدها باستخدام السيمكو زي ما شفنا قبل شويه، وكذلك باستخدام الباي مانوال إيريجيشن اسبيريشن. وانا يعني استخدم الباي مانوال إيريجيشن اسبيريشن. طبعا الفتحه الجانبيه انا افضل اعملها من 90 الى 110 ديجري من المين بورت، واعمل بالفتحه المقابله في الجهه المقابله لها تماما، واستخدم الجهتين لازاله الابينيوكلياس. اشيل الجزء المقابل. طبعا ندخل اولا بالإيريجيشن عشان نعمل فورميشن للاي سي، ثم بعد ذلك ندخل بالاسبيريشن ونشيل الابنيوكلياس من الجهه المقابله، وبعد ذلك نغير الاتجاه وندخل من الفتحه المقابله الاسبيريشن او فنريجيشن اولا، ثم الاسبيريشن، ونشيل الابنيوكلياس كامل. وانا افضل كذلك ازاله او البوليشنج للانتيرير البوستيرير سيرفيس الانتيرير كبسول، وهذا يقلل حدوث عتامه في الكبسول لاحقا. ويعني يمكن المريض يجي لك بعد 6 شهور الى سنه والكبسول فيري كلير وما يحصلش في موسز للكبسول. طبعا زي ما ذكروا الشباب او المحاضرين السابقين ان العدسات الراينر هي عدسات ممتازه، لكن تحتاج الى انتباه شديد في ديورنج يعني انجكشن، لانه احيانا ممكن تدخل مقلوبه، فيحتاج الواحد ينتبه الى في حاله العدسه انه تدخل الهابتيك الاول تحت الكبسول، ثم بعد ذلك الاوبتيك، ثم بعد ذلك الهابتيك الاخير. لكن في حاله حدث انه العدسه دخلت مقلوبه وما في مشكله، ممكن نطرحها امام امام الايرس، ثم بعد ذلك ندخلها. طبعا الميزه فيها انها زي ما ذكر الاستاذ الدكتور محفوظ انها ندخلها بشكل يعني داخل الباج من 1 شوت، يعني ندخل الهابتك الاول تحت الكبسول يعني تحت الانتيرير كبسول للباج، ثم بعد ذلك الاوبتيك، ونعمل يعني موفمنت معينه للانجكتور اتسلف، وندخل الهابتك الخلفي مره واحده. طبعا بعد ذلك زي ما ذكروا الاستاذ الدكتور عزيز انه المشكله في البيسكو انه احيانا يبقى معنا تحت العدسه، فانا افضل ان احنا نشيل فعلا البيسكو تماما من داخل الباج، سواء انتيرير او بوستيرير قبل ما نطلع. طبعا استخدام الباي مانوال استخدام ممتاز، بس يحتاج واحد يتعود عليه، بحيث انه الفكره كذلك في الوند هايدريشن انه نعمل هايدرو في يعني في الاوتر سيرفيس او الاوتر هاف اوف ذا كورنيا، يعني اللي يحصل معاه مثلا مره يعني ديسمنت داشمنت، ينتبه لهذه الخطوه جيدا، انه الهايدرو يكون في في الاوتر هاف اوف ذا اوف ذا كورنيا كذا. هذه الحاله بعد ذلك منكم استخدم البي هيكس دكتور 2 3 4 5 تقريبا او 6. طبعا البي هيكس نحن نستخدمه في حالات السمول بيوبل، فننتقل للانسيرشن اوف ذا بي هيكس. طبعا هذه حاله فيها السمول بيوبل، فالبي هيكس هو ميزته انه الانسيرشن تبعه من المين ووند. وبارك قدم للانسيرشن لو سمحت. طبعا هو افضل من الايريس هوكس كانسيرشن وكريموفال. نحن طبعا بعد ما نعمل الستيننج ندخل الايريس عفوا البي هيكس. انا استخدم المين ووند عشان ادخل 2 سايدز تبع البي هيكس، وبعدين ادخل من السايد بورت وادخل احاول اشيل. طبعا هذه العين كانت يعني مش قادر اشوفها، فاستخدمت سكند انسترومنت عشان اطلع العين او اعمل فيجواليزيشن، وبعدين امسك البي اكس واعمل اكسبانشن للبيوبل. طبعا هي ممتازه جدا كانسيرشن وكريموفال، وتسهل علينا العمل. لو سمحت الريموفال تبعها لو سمحت يا مبارك. طبعا بعد ما نعمل كابسول ريكسز ونشيل بعد ما نعمل فاكو اتسلف كامله، وهذه طبعا بالتشوبينج تكنيك نفس الفكره، وداخلين طبعا من فتحه صغيره وعملنا الفيكو كامل. حاول تمشي يا مبارك للريموفل. طبعا بعد ما نعمل انسيرشن للعدسه طبعا ننتبه بشده، لانه احيانا يحصل. ارجع شويه، ارجع للريموفل لو سمحت. ممكن واحنا اثناء الانجكشن للاي او ال ممكن البيهكس نفسه يسقط داخل الباقي، فننتبه يعني ننتبه خاصه للهابتك الثاني انه ما يسحبش معنا اوكي. طيب خلص كونكلوجن لو سمحت. طبعا بالنسبه كمان شويه بالنسبه للفيكو شوبينج تكنيك ممتاز والجود اوتكم في كاتراك سيرجري. طبعا اي جراح يستخدم يا الهوريزونتال يا الفيرتيكال شوبينج حسب التعود. شكرا جزيلا.
So next speaker دكتورنا القدير الكبير دكتور يحيى الغسالي. انت فين؟ بيقولنا البريميوم IOL the nightmares. It means the complication or disturbance while implanting premium intraocular lens. You are welcome.
هذه المحاضرة الوحيدة التي ما تعجبش الدكتور يعني النايت مير حق الايول.
مرحبا. وقت اخر طبعا الكل اتكلم عن المميزات بشكل عام بالذات التريفوكال. احنا نتكلم عن الجانب المظلم فيها، الأسوأ ما فيها. نقلب. بس. I have no any financial interest with this any company. اقلب يمين ما بيقلبش. البريزنت داي IOL يوزد من المونيفوكال البريميوم. البريميوم عده انواع من المالتي فوكال، التوريك، الترايفوكال، الاكستندد ديبث حديثا. طيب الادفانتج اوف بريميوم IOL. واي بريميوم IOL ذان مونوفوكال؟ البريميوم IOL جنرالي لما صنعوها بحاول تغطي او توصل للنورمال. نحن نوصل للنورمال نشوف الفيجن الفار والنير بشكل متساوي. طبعا ما يوجد من العلم الا قليلا مهما كانت كل الكمبانيز اللي عملت المونوفوكال البايفوكال بعدين الترايفوكال الملتي فوكال بعدين الترايفوكال حديثا ما زالت الليميتيشن فيها عالي، يوصلوا للبرفكشن. على الرغم من المميزات الموجوده المذكوره في الترايفوكال حديثا، لكن ما زال هناك مشاكل كثيره بتواجهنا في الترايفوكال. من اهمها نايت ميرز. ليش دائما الجراح لما ننزل على الترايفوكال بنتعرض دائما لنايت ميرز؟ دائما تفكر في المريض، دائما عندنا ايش ممكن يحصل للمريض. نايت ميرز means patient unhappy. Why patient unhappy? post trifocal or post multifocal. Residual refractive error. For residual refractive error means that IOL calculation was wrong, our biometry was unequal. الفيسكو الاستيك زي ما ذكروا الشباب، زي ما ذكر الدكتور عزيز بيتر فلويد، لما بيجي شويه فيسكو الاستيك خلف العدسه بيحصل لنا مشكله بالتغيير الريفراكشن تماما، بالذات بعد الترايفوكال. remaining cylinder. الترايفوكال contraindicated if you have corneal cylinder more than one diopter. either use trifocal مع توريك او تستخدم الايش المونوفوكال او توريك الون. طيب الاذر consideration dry eye الان بيعتبر حديثا one of the major causes of residual refraction post biometry. بيعمل a lot of biometry mistakes. طيب unsatisfied patient. هذه واحد من بدايه المشاكل اللي بنواجهها من المرضى لما نشتغل ترايفوكال او نير انتي فار فيجن. الهاي اكسبكتيشن اوف بيشنت. معظم المرضى بعد عمليه بالذات الفيميلز بتزرع على ترايفوكال تعتقد انها ترجع للنورمال، بينما الترايفوكال جنرالي بتعمل الدايلي تاسك العاديه. تقول لك بعد العمليه مش قادر اشك الابره. طبعا it's very difficult to use it with the trifocal. الاوسيسيف بيشنت موست بيشنت اللي بيشوف اللي يحتاج انه يشوف زيرو ريفراكشن في الورقه حق الريفراكشن. هذا دائما من المشاكل لنا لان جنرالي الترايفوكال والمالتي فوكال ما في الاوتوريفراكتيف كيراتوميتر ام فاليد في الحالات هذه. موست كيسز اوف ترايفوكال لينزز امبلانتد بتعمل لنا -1.5 1.75 post operative which is normal. الاوكيبيشنال نيد patient driver at night has contraindicated to use the multifocal or trifocal because they have الجليرز والهالوز اللي صار لهم بوست even if he has good vision during the day, at night he will complain. طيب validity factor effect meter. طيب I'll speak on some cases that we have faced during implantation of trifocal. First case, هذه will have consult me. Patient have implanted bilateral trifocal IOL, which was good in the left eye. While in the right eye, he has surgeon has vitreous loss during surgery and implanted partially in the back. So generally, eye is okay, but the refraction was unstable. Important things here is that the patient is 70 years and she is illiterate. Why you implant a trifocal for a illiterate patient? I don't know, really. Second case, if you just notice there, I have implanted this is one of the special cases. In the first case, in the first photo on the right, IOL after implantation, the trifocal, the center of the pupil is not consistent with the center of the trifocal, and you generally you imagine you find that after surgery, and the patient complain of halos and glare all the day and the night, and the other problems, he have unstable refraction, so he cannot see the far clear and near the near nor the far clear. Even with dilatation, the IOL is centered and well, but after the pupil gets smaller, the center of the pupil and the center of the IOL was not consistent, and so what we'll do is just we go and remove the lens and put monofocal lens. Fourth case, bad quality IOL. This patient has referred to me with this refraction post trifocal. As you say, this has +3. +3 is not normal after trifocal. Minus is okay, is accepted, -1, -0.5, but +3 means the patient cannot see the far, and he has an addition +2.5, so he has +5 post for near. So what we'll do for this, even the surgery was very good, and the trifocal is very centered. I have revised the case. I did calculation and this patient for IOL master calculation, and we have this calculation. Patient has around 22 lens. So I have asked for the lens implanted that maybe some mistakes during implantation of the lens. We find that the patient has implanted 22. So he has implanted the same lens. So where is the problem? I have a consultation with some colleagues of refractive surgeons. They said that finally you have to remove the lens because it is a bad quality lens. So what we do is just we remove the lens and we put another lens 22, which was with the one with a good quality lens, 22 again from Ray1, and give a very excellent result in the refraction post-operative. Fifth case, this case is challenging, and I want some opinion from some refractive surgeon here. This patient was 35 years old, female patient. She has bilateral mature cataract, developmental cataract, and she has this refraction. She has 24 lens calculation. We call also for IOL master to be sure and give the same result, 24 calculation lens. And they have implant a good IOL from Ray1 trifocal, and unfortunately post-operative we have this surprise refraction +2.5. Why this patient has this refraction? Can anybody have an idea about that? Biometry was normal. Okay, everything was okay. The IOL master and the ultrasound give the same result. It's normal. The IOL is well centered. So we have this. If you see, the patient has flat cornea, which even with the best IOL master, it still give a post-operative surprise and they give +2.25 after surgery. So what we will do again, we will go in after 1 week and remove the lens and put, instead of 24, we put 26 lens to improve the patient refraction. Finally, he is satisfied. Finally, trifocal is a good lens, but you have to counsel the patient very well and do examination very well, take care of some cases, and you can implant many cases, fortunately good, and have to sleep comfortably without any nightmares. Thank you.
Next presenter, Dr. محمد الحميري. بس ايش ضحك الموضوع؟ Dr. محمد الحميري, he will talk about Ray 1 aspheric in glaucoma patient. خلاص باقي ذاك واحد.
السلام عليكم. طبعا يعني الوقت ضيق وجمعة وهكذا، فاحنا نشغل بس 2 فيديوهات بسيطة. This is a case of topical phaco trap. فاحنا في التوبيكال فاكو تراب بيهمنا اكثر حاجه اللي هو السكليرال فلاب، فنعمل سب كونجكتيفال انستيزيا ليدوكاين ونعمل له ديفيوجن، وبعدين بنعمل انجكشن للميتومايسين. نفس الحكايه بنعمل له يعني زي المساج على اساس تو diffuse all over the fornix, creating conjunctival cautery should be very light. The patient is still sensitive to heat. Creation السكليرال flap. And then moving to the phaco. Irrigation to the cornea will irritate the patient movement. عشان كده نحط فيزكو, especially when we are doing capsulorhexis and putting intracameral phenokine. Phenokine is a local anesthesia and also mydriasis. Creating a capsulorhexis. And then doing a hydrodissection, movement of the nucleus, and start doing phaco. This is divide and conquer. In topical anesthesia, while the probe and the tube are inside the AC, the eye is stable and you can control the eye movement. And then irrigation aspiration, I prefer to use Simco. Dr. Rehawa Salim, I Simco. I prefer to use Simco in cataract surgery while I am doing also bimanual. And then insertion of Rayner IOL, which is very easy and simple insertion and very smart lens. After finish phaco, we can move also to the trap part to finish it. In topical phaco trap, we don't use any bradle suture, either corneal or superior rectus, because the patient movement will help us to see the surgical field. We just ask from the patient to sit down, and then we just do the trap easily. And then meticulous closure of conjunctiva. Next case. This is also phaco trap, but this patient has a small pupil with zonular dialysis. Same steps, creating a scleral flap. And then start phaco. In this case, I used B-hex. B-hex ring is very nice ring to dilate the pupil, easy insertion and easy removal. Will give us a very nice surgical field, and the pupil dilatation will be 5.5 millimeter, which is enough for capsulorhexis. Since the patient has zonular weakness, so I prefer in these cases to do a little bit large capsulorhexis, so we can work easily. And then we start doing, Fico chop is better in these cases. The nucleus is a little bit hard, but doing dealing gently with cases like this, especially in tubing, and you have to نوزع الباور لما الباور اللي هو البريشر اللي بنعمله لأنه في zonular weakness. Otherwise, if there is severe zonular weakness, we can start doing CTR from the beginning. In this case, after I finish the tubing, I prefer to put CTR. So CTR هنا putting it using 2 dialers. It is, we should put the CTR starting from the zonular weakness area. And then we use 2 dialer just to ensure that the ring is inside the bag and not outside. The problem here, after we doing a CTR, it is a little bit difficult just to do aspiration, because the remnant, cortex will be just held by the CTR, and then insertion of the Rayner IOL, which is very simple and easy in cases like this. After just we finish, centralize the IOL, and then remove the B-hex, which is easy to removal by single step only. So B-hex will make your life easy, and then finish the trap as usual. Thank you very much. Thank you.
دكتور محفوظ تفضل. دكتور محفوظ هاي كلمنا على سكليرال فيكسيشن.
السلام عليكم. المحاضرة اللي حقدمها الآن برضو فيديو بريزنتيشن عن سكليرال فيكسيشن. طبعا نحن نستخدم عدة أشياء للسكليرال فيكسيشن. حاليا أشهر تكنيك هي اليماني تكنيك. طبعا هي طريقة ممتازة جدا، وأكيد الجميع كان شافها وبعض الأطباء بدأوا يستخدموها، لكن اللي أستخدمها أنا ما زلت حاليا هي سكليرال فيكسيشن باستخدام عدسات راينر. كمعلومة بس بسيطة، أنه معظم الشركات الأساسية في اليمن انسحبت بسبب الوضع العالمي، لكن راينر هي الوحيدة اللي بقت حتى الآن، فنشكر الجزيرة والخليج. كلام حلو؟ طبعا سكليرال فيكسيشن هي عملية مش سهلة، لكن مع التكنيك ومع الخبرة بتطلع عملية سهلة. فأكيد اللي زاروا الشباب كبكبان يعرفوا المنطقة هذه بشكل أفضل. السكليرال فيكسيشن هي عملية بسيطة جدا، نحن الهدف منها نزرع العدسة ونربطها بخطاطيف أو بالسوتشرز. هذه هي الانديكيشنز تبعها. والسوتشر ماتيريال اللي نستخدمه، نحن نستخدم البولي بروبيلين. الاي او ال تشويس زي ما قلت لكم، نحن اللي نستخدمه حاليا هي الراينر، وهي موجودة معنا لأي حالة. أنا حاجيب لكم حالات متعددة للسكرينال فيكسيشن. طبعا لازم تعرف أنه العملية الواحدة قد تأخذ مرات نص ساعة، مرات 40 دقيقة، مرات ساعة، فلازم الجراح يكون جاهز إيش للتعب. هذه مريضة تعرضت لضربة فصار عندها سبلكسيتد كاتاراكت، فالديسيجن هو انتراكابسولار أو فيكو مع انتيرو فيتريكتومي مع سكليرال فيكسيشن. شغل لي الفيديو. طبعا أنا حاولت في البداية أعمل لها فيكو، نفس التكنيك اللي عملوه الزملاء، هي تكنيك متكررة فيجن بلو. بس أول ما بدأت أعمل لها الكابسولوريكسس بتلاحظوا إنه اللينس كلها إيش سبلكسيتد. فأنا قلت خليني أكمل إيش المشوار إذا في مجال أعمل لها فيكو. عملت الكابسولوريكسس. في الحالات هذه اللي فيها زونيولار دهيزنس نحط كابس ايش اسمه ايريس هوكس، او يسموها كابسول هوكس، المتوفر عندنا الايريس هوكس. بعدين عملت لها الفيكو، لكن خلال الفيكو كل اللينس خرجت ايش مره واحده، فبالتالي على طول بدات اعمل لها ايش بتريكتومي، وشلت الايريس هوكس وسويت ايش الكومبليت بتريكتومي للانتيريور بارت. هذا هو الكبسول كله ممزق، فما فيش مجال نعمل اي حاجه، فعلى طول عملت لها كومبليت بتريكتومي. بعدين بدات اعمل لها سكليرال فيكسيشن. سكليرال فيكسيشن نعمل تو سايدز اللي هي على الجنب اليمين والجنب اليسار، نعمل كوتري، وبعدين نبدا نستخدم السوتشر البروبرلين، ندخله من جهه ونسحبه من الجهه الثانيه باستخدام الكانيولا تبع الفيسكو. نربط اللينس باعتبار انه اللينس اللي هي الرينر فيه بها الاتاتشمنت هذا، فبنخيطها في الجهه هذه والجهه الثانيه، وبعدين نثبتها في الجهتين. طبعا عمليه هي متعبه شويه لكنها نتائجها رائعه جدا. بعدين بايلو كاربين، وفي كل الحالات انا اعمل لهم peripheral iridectomy. هذه نتيجتها مع بلس 2 مع ماينس 1 2025 very happy patient. لكن بصفة عامة يعني زي ما قال الدكتور يحيى انه البايومتري is very important، فبالتالي لازم انتم كأطباء اذا فتحتوا عيادات تستثمروا في البايومتري ماشين. تمام. ضيعت لنا الصلاة في المسجد. تمام. الآن هذه حالة ثانية، تشغل الفيديو يا مبارك. هذا التروماتيك بيشنت عملنا له رابتشر جلوب مع ريموفال اوف لينس. الآن ندخل نعمل لهم سكندري IOL باعتبار ما فيش أي طريقة نعمل له ايرس كلو ولا شو اسمه سالكس فيكسيشن. عملنا له ايش سكليرال فيكسيشن، نفس التكنيك نعمل في الجهتين. نعمل له شو اسمه تحديد للوند عشان يدخل السكليرال ووند، بعدين نفتح الوند نعمل انتيرو فيتريكتومي. فعشان كده زي ما قال الدكتور نبيل في البدايه والدكتور عزيز، وجود الانتيرو فيتريكتومي في عيادات الانتيرو سيجمنت is very important. بعدين طبعا اللينس هذه is very good، يعني لما تخيط ما بينقطعش الخيط معاك، وعدد الحالات اللي شفتهم انه سقطت اللينس او افتك الخيط very rare الا اذا كان في تروما محترمه يعني. فبعدين بنزرع اللينس. بعد ما نزرع اللينس نخيط الجهتين، والستابيلايزيشن دائما ممتازه جدا. طبعا اذا لقينا البيوبل كبيره ممكن نعمل لهم ايضا بيبيلوبلاستي. الريزلتس تبعها دائما ممتازه جدا. بعدين نخيط الجرح. في حد منكم زار مناخة؟ beautiful very beautiful، ممكن توقع في السحاب إذا قدرت توصل. الفيديو شغل لي. هذه طريقة يعني طريقة حضرمية، يعني اللينس نفسها صار لها سبلكسيشن، فبدل ما نخرج اللينس ونرميها إيش نسوي؟ نستخدم نفس اللينس. فبالتالي هذه اللينس صار لها سبلكسيشن نتيجة تروما. فالطريقة الوحيدة لعلاجها هو ان احنا نجهز للسكرين فيكسيشن، نفتح الوند، اللينس السبلكسيتد نخرجها. بعد ما نخرج اللينس سبلكسيشن طبعا الكبسول الانتيرو والبوستيرو كله مرتبط فيها، فننظفها، وبعد ما ننظفها نرجع ايش؟ نستخدم نفس اللينس. فنستخدم اللينس، فالمريض يخرج مبسوط ونحن وإداريا مبسوطين. الخسارة ايش؟ خفيفة جدا يعني. فنحط السوتشر ونحط من الجهة الثانية السوتشر ونخيطها، والمريض البايومتري حقه لأنه استخدم على نفس العدسة السابقة ونخيطها. دائما النتائج فيها ممتازة جدا. المريض الفيجن حقه 20/40 beautiful مع plus 0.75 توصل 20/35. المهم هذا المريض أجى لعندنا برضه تروماتيك سبلكسيتد لينس، بس اللينس مش زي الحالة الأولى سبلكسيتد كاملة، جزء منها، فبالتالي شو نسوي؟ نستخدم نفس اللينس بس نخيطها في الجهة اللي ايش؟ سبلكسيشن. يعني لازم تكون حضرمي عشان تفهم ايش كيف تستخدم ايش اللينسز بدون ما تتخلص منها. فنفس اللينس نخرجها نربطها ونخيطها ونرجعها زي ما ايش؟ زي ما كانت. طبعا البديل الآخر انك تخرج اللينس زي ما قال الدكتور عبد الرحمن، إذا كانت not good lens لازم تخرجها، لكن أنت عارف إنه هذه اللينس هي very good lens، أنت اللي زارعها، بس حسب المريض تروما فتستخدمها نفس اللينس. طبعا في فيتريس أجا في هذه المنطقة، بعد ما تثبتها تعمل له شوية anterior vitrectomy. إيه خلاص آخر فيديو. فنعمل له شوية anterior vitrectomy ونخيط السوتشر، وبعدين نثبت العين. طبعا كون ما فتحناش اي حاجه ما فيش داعي نحط له اي خيوط، نخيط بس الكونجنكتيفا. فالسكليرال fixation technique using the Rayner lens is a very good lens.
الأخ مبارك، الدكتور خالد بحارثة فيديو جاهزة نشتغل آخر فيديو إن شاء الله اليوم، وبعدين دقيقتين 3 دقائق الدكتور اياد يسحب هذا، وبعدين نروح نصلي إن شاء الله. تفضل يا أخ مبارك.
With you, Dr. Khalid Mubarak Baharitha, ophthalmic consultant in Hadramaut University. Today, we speak about these lenses, in my experience, about this Ray 1 preloaded IOL. So we speak our experience with these lenses. These lenses we implanted more than 1,000 implanted of these lenses. So this lenses Ray 1 hydrophilic give me very excellent refractive outcome, very excellent visual acuity or vision. And this character of this lenses because has more clarity, stability, and the capsule back and centration. So the specification of these lenses include first one piece artobot observing acrylic monofocal lenses with a posterior aspheric profile, and second overall diameter is 12.5 millimeter with an optic diameter of 6 millimeter. And third and fourth and fifth is very important character of these lenses. The first one was this smooth implantation in the capsular bag, more good injector, and we inject these lenses in 2.2 millimeter incision with maintaining this incision architecture. Another character, fourth character is long-term stabilization of these lenses and centration in the capsular bag This character is from its haptic, the anterior and outer. Haptic of these lenses give more long-term stabilization. And these character are very important in the results of these lenses in the vision. And these another, the fifth character was minimum posterior capsule ossification. Minimum cases of posterior capsule ossification, and this consistency of these lenses or character of these lenses to this is type of is hydrophilic lenses. Is hydrophilic lenses. So these hydrophilic ion give good result in vision, long-term vision. We show this character. You see this video, like we do this implantation of this. Ray-1 hydrophilic in the posterior capsular bar. So it's easy or soft implant in injection. So it's more like more centration in the capsular bag. So about this Ray-1 hydrophilic periodic lenses was safe. It's safe for complication, limited follow-up, refractive power outcome were excellent, and is reflecting the stabilization and predictable effective lenses in position. Easy to use with good stability and centration in all cases. And this is the desirable character for our surgeon in ophthalmology. And this is our center.
مسجل فيديو مسجل.
This is my country, city in Mukalla.
Okay. Yeah.
Thank you for your attention.
Okay. Thank you everybody for your thank you for your attendance. Thank you for everybody, and thanks for your attendance to this valuable scientific meeting. We get a lot of benefit from all our colleagues. We get benefit really, you know, from all our colleagues. We are very thankful for them for their presentations. And now we have بيمة. هنعمل بيمة قرعة البيمة القرعة. شركة جزيرة والخليج بتعمل سحب على التذاكر. إن شاء الله تكونوا I hope that كل واحد منكم يكون إيه هو صاحب الحظ. أهم شيء الدكتور محفوظ ما يكونش في الوسط، لأنه كل ما نعمل قرعة يجي هو ما نشوش ما يدخل حق الكارت يخرج برا على. طيب السلام عليكم ورحمة الله وبركاته. أنا مش أول شيء أنا أتشكر جمعية أطباء العيون مرة أخرى على إتاحة الفرصة لرعاية اليوم العلمي الرائع، وبتشكر رئاسة اللجنة البروف عزيز شاهر وأستاذنا الدكتور إبراهيم الحمدي على إدارة الجلسة الثانية. طيب أنا مش هاخذ من وقتكم، إحنا هنعمل السحب سريع، بعدين في الصلاة في الجامع، بعد ذلك بنلتقي إن شاء الله مع بعض في المطعم إن شاء الله، في مطعم مؤسسة الشيباني. مطعم مؤسسة الشيباني عند بريد حده. أوكي؟ طيب نقول بسم الله. أسحب أنا ولا واحد يسحب؟
هاي الأولى جائزة لحظة حطها يا بابا. الجائزة الأولى قيمتها 60,000 ريال، عبارة عن عدسة راينر راي 1. محمود أحمد عبد الرفاعي موجود؟ تعال. جيبها. الجائزة الثانية عبارة عن عدسة راينر راي 1 قيمة 60,000 ريال من مغربي. لا مش انت يا باشمهندس. دكتور نجيب القرشي. دكتور نجيب بدنا الورقة دكتور نجيب. الجائزة الثالثة برضو مقدمة من راينر، عدسة راينر راي 1. لا معقول المستشفى المغربي. دكتور عبد الصمد عبد الرب. انا ما لي دخل يعني، انا لا تقول لي شيء. الجائزة الثالثة عبارة عن عدسة راي 1. هو شاهر بس مش الدكتور عزيز. هلال غازي شاهر. الجائزة الخامسة برضو عدسة راي 1 ريلودد اي او ال 60,000 ريال. هاي المرة مستشفى نور اليمن. تميم مطر خرج. نلغيها ولا نخليها؟ خذ اعطيني واحدة. سحب على اول لابتوب. سحب على اول لابتوب مقدم من رينا. مرحبا. فيميل هي اسمها زي الماسة. جوهرة احمد محمد طاهر. جوهرة الثالث. جائزة السادسة عدسة راي 1 لسامي عبده محمد الزريقي. مش موجود.
الذي ما يستفيد من العدسه ممكن يبيعها للشركه بنص القيمه. الذي ما يستفيد منه، انا اكلمك بجد يعني، اصلا ايش اسوي؟
هاي تلغى، مش موجود. اعطيني واحدة. محمد ناصر الشغدري. مغربي يعني مش فاهم انا.